Okay, so anesthesia for neurosurgery. So let's get cracking. So the most important thing here is that I've got lots of stuff that I keep creating on the YouTube channel. I've got a playlist called the Final Exam playlist, and that's probably the most useful thing when it comes time to learning other stuff. If you just want a change of the way you're studying, and any of the courses I'm running will be an Anesthesia Collective. I've got an IMG exam course. That's that QR code and final exam course for anyone who's just started studying. That's I'll go through a study plan and short answer question and MCQ kind of stuff, and then the Vivas as well, and all of my Viva Bootcamp courses on there as well. This is session 2, so hope you guys enjoyed whoever came to session 1. For session 2, we're going to go through more things, which is essentially Viva stems, critical inductions, immersive crises, and yeah, we'll hopefully get cracking on with that as well. Good. So this is the actual lecture. That's a playlist that's available on YouTube with all of this, just in case we don't get through everything. So again, I'd rather people just keep it really relaxed, ask whatever questions they want, and we go through it at whatever pace that this goes through. Now, this is the way. There's obviously quite a few topics to cover with neuroanesthesia and neurosurgery. You know, you've got your subarachnoid hemorrhage, AVMs, head injury, C-spine. There's positional issues, ICP monitors, awake crania and craniotomies, and yeah, the Viva and transpenoidal issues as well. And to me, the Viva framework really is like a pre-op framework, anesthesia knowledge stuff, crisis management stuff, and then a few trials and professional documents, which we won't need to go through in this one. So that's pretty much what I'm going to try and get through in this lecture. Yeah, again, I'll just try to put as much I'll try to put as much technique stuff as possible as well. Okay. So we're going to try and cover as many core neurotopics as possible, concise formats, and compile a comprehensive set of notes, and get a taste for SAQs and Vivas. Hope everyone's got a pen and paper ready, so I'll just get you guys to write down answers. And even if I'm asking a question of one person, please commit to an answer. You know, a lot of this exam, a lot of memory is just about active recall as well, so please do that. Lots of questions, SAQ practice, Viva answers, and systematic ways of answering stuff. Okay, so first thing we'll go through is subarachnoid hemorrhage, and the very first thing, now, whenever I get asked something about, you know, tell me about subarachnoid hemorrhage, it might be a first question, maybe in the SAQ, you just need to get lots of content down. I find that this framework is really easy. I think there's, I forget who said this, but, you know, 5 people told me everything I knew, and that's who, what, when, where, why, how. Maybe that's sick there. I want you guys to just write down in the next minute as many things as you can that you know about subarachnoid hemorrhage, and just use this framework to see if that helps you just recall stuff, even if you may not have memorized it, you know, in the last month, week, day, hour. So take a minute, and I might just ask someone to volunteer actually for this one in a second.
Okay, I can jump in. Sorry that my microphone's a bit rubbish. So this is a minority of strokes, like I think it's about 5%, but really overrepresented amongst mortality. The numbers I had was that 40% die, but like 50% of survivors have a significant neurological impairment. The vast majority occur secondary to an aneurysm rupture, typically at the circle of Willis, although they can also be associated with AV malformations anywhere else in the brain, and there's sort of the weird and wonderful things like Moyamoya syndrome and those sort of congenitally associated vascular abnormalities. I think the other associations that spring to mind is polycystic kidneys and possibly Ehlers-Danlos, but I'm not totally sure about that one, as well as sort of more generic risk factors of atherosclerosis, I think smoking, alcohol, cocaine, and uncontrolled hypertension. And I sort of already answered the prognosis bad.
Oh, that's great. Hey, Emily, I don't know how you did a brain transplant in that time, but I think it worked. So who, female greater than male, peak incidence 50s, incidence 2 to 5%, numbers were great. Anterior circulation, and has aneurysms, can cause a subarach or AVM vasculitis and dissections. And associations, yeah, you're absolutely right. So there's so many different things that can cause it. And only a couple of those are really relevant, I guess, for anesthetics, but we'll go through that later. And like a lot of things, hypertension, other vasculopathy risk factors also important. So yeah, 10% die before hospital, 25% die in the next 48 hours, and 40% make a good recovery. So really quite tragic stats there. And really, a lot of it depends on age, conscious state, and the amount of blood. So good. Again, just a framework. Just think about that. You're in the SAQ. You got asked a question that you just haven't thought about in a while, and you just need headings to allow yourself to put in data. And even like, Emily's answer was really comprehensive, but even if you just said a few of those things, like you just thought, who is it? Oh yeah, most of these kind of vascular kind of things are female greater than male. And yeah, I think a lot of us remember that it's peak incidence of, in the 50s. If you just remember a few of these facts, it just helps you get marks where you otherwise may have not got marks. Again, it's all just strategy for this exam. Okay, now there's various classifications. I might just ask someone, Grace, what kind of classifications for subarach have you heard of?
So you can have a clinical classification, which is the World Federation of...
Oh, sorry.
Sorry, can you hear me?
Yeah, I can hear you. Go
for it. Sorry. So there's the clinical and radiological classification. So clinical is the World Federation of Neurosurgeons classification, which is mostly based on GCS and their motor deficit. It's class 1 to 5. And then there's the Fisher grading, or modified Fisher grading, which is on a radiological, on the CT findings. So, and that's to do with the thickness of the blood and whether it's intraventricular or not. And there's 4 grades.
Yeah, excellent. So you had the World Federation score, and did you mention Hunt and Hess?
No, sorry, I didn't.
Do you know what that's about?
It's also clinical grading, but I just found the World Federation of Neurosurgeons easier to remember, so I didn't really memorize how to classify it.
As did we all. And maybe someone has this answer. I always wonder about this. Like there's the Hunt and Hess, which is kind of old, and it's kind of hard to remember and memorize. But I imagine a lot of the studies have been done through Hunt and Hess. Does anyone know of any correlations between Hunt and Hess and the World Federation scores, and how we can, how we can extrapolate the studies that were done in the past? Does anyone have any feeling about that?
I can't really compare those two scoring systems, but between the WFNS and the Fisher, the Fisher is more useful for predicting subsequent vasospasm, whereas the WFNS is more useful for predicting prognosis. But I'm not sure about Hunt and Hess. I feel like I've really ignored that one in my study. I should.
No, that's right. I think knowing the name is absolutely fine. So for everyone who doesn't know this, if you're ever going to learn any scale, it's going to be your Fisher and your WFNS grade, and it's reasonably easy to memorize this. Grades 1 to 5, and really the GCS scores here are 15, 13 to 14, absent or present motor deficits, and 7 to 12, where it doesn't matter, and 3 to 6, where it doesn't matter. I'm pretty sure there's a multi-choice question on that. Hunt and Hess grade, it really it's a lot harder to memorize when you've got very irregular categories of things. One's mentioning confusion, another one's not. It just seems very difficult to memorize. I'm pretty sure your MCQs were pretty much on just the WFNS. And as you mentioned very correctly, this is a CT classification where it looks at grades 1 to 4, no blood, less than 1 millimeters thick blood, greater than 1 millimeter thick, and any kind of intraventricular or intraparenchymal extension. You're correct that then is a predictor of vasospasm. Okay, so let's keep moving on. How do you assess any patient? Now, I've always been wondering how to exactly do this in the Zoom format. Let's say I might ask Siak. Siak, I'm a 50-year-old male, and I've come in with a grade 3 subarach, And let's say you're in the form of doing a medical assessment on me. So you're not going to do any kind of anesthetic related questions. This may be related to, say, a medical viva or even your short answer questions. I guess I just want you to ask me some questions, you know, on assessment, and I'll volunteer the information. I just want to see what your format is.
Sure. Okay. So, Lahiru, what's brought you in today?
Yes, I've got this headache, and yeah, they've told me it's a pretty bad subarachnoid hemorrhage.
Okay. Whenabouts did this headache start, and have you had these headaches previously?
Not first time, and just started today. Came to hospital straight away.
Okay. No worries. And these headaches, have they been associated with any visual changes?
No.
Okay. Any weakness or numbness in your hands or legs?
No.
Any problems walking around picking up cups?
No.
Okay. These headaches themselves, where are they located? Is it front, back, side of the head?
Back.
Okay. And has it changed at all over the course of the last couple of hours that you've had it? Has it worsened, improved, or just stayed the same?
It's been pretty steady, yeah.
Okay. Have you had associated vomiting?
Yes, I had a couple of vomits, yeah, maybe a couple of hours ago.
Okay. And what were you doing at the time when these headaches occurred?
Nothing. I was just woke up, walking around.
So did the headache wake you up from sleep, or did you wake up with the headache?
I can't remember. It could have been just after I woke up.
Okay. All right. And you said you've never had these before, didn't you?
No.
Okay. In terms of your past medical history, Lahiru, what can you tell me about any medical issues that you've had?
Oh, look, I'm a bit confused at the moment. What do you want to know?
Do you have high blood pressure, for instance?
I do, yeah.
Okay. And would you take medication for that?
Yeah, I'm just on atenolol.
And do you take your atenolol as prescribed?
Yep, just once a day.
Okay. And have you seen your GP for your high blood pressure? Is it well controlled?
Yeah, it's normally well controlled.
Okay. Any other past medical history, Lahiru, that we need to know about, in particular, any heart problems?
No.
Okay. Diabetes?
No.
Okay. And in terms of medication, do you take anything else?
No, that's it.
Okay. So you only take your atenolol?
Mm-hmm.
Okay. All right. Okay. In terms of surgeries, any previous surgeries, Lahiru, particularly in the head and neck region?
And none at all.
Okay. And in terms of your daily sort of exercise tolerance, would you say you're otherwise fit and healthy? Do you go to the gym?
Yeah, completely fit and healthy. Unlimited by most things.
Unlimited. Okay, sure. All right. Drinking and smoking?
Smoker, but non-drinker.
How much do you smoke and how long for?
Let's say you complete the smoking history, keep going.
Okay. Now, I'd just like to take an examination of you, Lahiru. It would be a targeted examination looking at a set of vital signs. And in particular, what I'm worried about...
Instead of asking me that, you tell me what you're going to look for.
Yeah.
In exam.
So, yeah, what I'm particularly looking for are lateral facial signs of CVA, so facial droop, dysarthria. So I get them to you kind of get that passively through your history as well. Mm-hmm. And any signs of, I do a very quick kind of visual acuity assessment, just making sure that there were no visual deficits. I then look for lateralizing signs, particularly gross motor movements and gross sensation deficits. Mm-hmm. I then look for some risk factors, trying to rule out the life-threatening and more serious signs of headaches. Mm-hmm. So particularly with that, I'd take a look at the neck, looking for signs of raised JVPs. Mm-hmm. I'd have a listen to the precordium, listening for signs of murmurs, potentially aortic stenosis or carotid bruits. Mm-hmm. I'd then move laterally, having a feel of the pulse, the rate, rhythm, and character, and just having a feel and look for any signs of.
So I noticed that you're going through the cardiovascular system like examination. Let's say you complete that, and you've done a neurofocus exam as well. I think that's great. Yep. Keep going.
Yeah. So I think at this case, what I'd want are some simple investigations at the bedside. So I'd want an ECG.
Yep.
There are some worrying signs on your history, particularly with the vomiting, sudden onset, and the fact that you've never had this before. And I think given that you're 50 years old with a background history of hypertension, I think CT non-con is warranted just to screen for any sort of subdural or subarachnoid hemorrhages. And that would be my initial.
Yep, so that's great. So Siak, that was a really comprehensive history. And now, one of the things I noticed in this exam is that if I was to ask someone a question, each time I suspect, first of all, between different candidates, they'll answer it very differently. And sometimes within any one person, they'll answer it differently. So what I'm a big fan of is having really, you'll hear me say this so many times, but having really good structures and also knowing what structures you're going to invoke in any particular circumstance. So Siak, what structures were you thinking of as you were doing, answering this question?
I guess, for me, headaches are really common presentation, but what I wanted to know were your life-threatening causes, and therefore I targeted both generic but also specific parts of the history, looking for red flag signs. And you had a couple that you eliminated, so no lateralizing signs, but as I said, there were a couple of worrying signs amongst that would be attributed to maybe an intracranial hemorrhage. I've focused on mainly sort of cardiovascular and neurological diseases, because I think that's just where the red flags are. And then an examination, again, that's where I focused my examination. And so that was the kind of the structure, but history, examination, investigation, symptoms, past history, and then meds and social history.
Good. So I did notice that. So you went history, examination, investigation. Now, I also noticed that you asked risk factors. So I may have not made this obvious that this patient came in with a grade 3 subarach. So completely, if they came in with a headache, you go through the whole headache history. That's completely fine. And you specifically asked some of the stuff about, smoking and hypertension. Is there any other things? Let's say this patient was pretty vague and had a decreased conscious state. What things would you want to look for as the cause of this problem? The weird and wonderful stuff.
Okay. I guess the weird and wonderful stuff. So if we think about Ehlers-Danlos and Marfan syndrome, I think the key things to look for there are the overall phenotype of the patient, essentially tall, hyperlaxity.
I'll stop you there. That's exactly what I want to hear. And just remember that this is difficult in the exam, because what happens in real life is you get a patient who's already medically worked up. This exam makes it a little artificial sometimes, because they will say, you've got this patient and now you've got to actually fill in all of the gaps that are already filled into you by the medical teams. So in this circumstance, for you to say, I'll look at my risk factors, hypertension, smoking, whatever, and also write down or mention Ehlers-Danlos, hereditary, telangiectasia, and Marfan's as well, because they're anesthetically relevant. That's like some decent marks right there. Now, you mentioned a few things, and I think we stopped before you mentioned, what are all the complications that you could get from this subarach patient in ED that you could be looking for? And you mentioned some of these in your exam as well. What are they?
Okay, so I guess the immediate complications from your subarachnoid hemorrhage may include obviously decreased GCS and therefore decreased ventilation, hypoxia, and secondary cerebral ischemia or MI. I think other things associated with subarachnoid hemorrhage include ST elevation and cardiac dysfunction and arrhythmias secondary to that. I think you can also get like acute pulmonary edema secondary to severe subarachnoid hemorrhage, though I do note this is a grade 2 to 3 subarach. What else? That's sort of what occurs to me at this point. I probably missed a couple.
No, that's great. And so my point of this is that this exam, because we're usually treated with, in the context of really great medical teams that sort out and inform us of a lot of these things, we don't have to be as thorough often in real life. But in this exam and in real life, we should be really thorough. And so you'll hear this thing of severity, stability. I always like to add cause and complications and be very prescriptive about mentioning and asking those. what are the complications, and then I think of specialist management and meds and the complications of these, because these have a whole bunch of issues as well. Now, when you were going through your history and examination investigations, you're absolutely doing it appropriately. You took a good history, examination, investigation, and then the extra points you get after you do, after you fill in the past history, past anesthetic, past surgical history, allergies, medication history, family history, social history, examination, investigations. The way you get those extra points is, I think, to use this framework, because you get lots more causes, because you're thinking like risk factors, causes, and you're thinking about the complications. Like there's, an MI isn't just an MI, an MI is a whole bunch of other stuff that caused it, and then all the things that it could be causing now: heart failure, arrhythmias, maybe even valve rupture because the MI was that bad. But you're thinking about these things, and maybe they've got a defib in now, and that's now got its own issues, and checking that and everything. So this framework, it helped me just make sure I got everything out. Football female theatre with grade 3 subarach. How do you get to the crux of the questions, the points that differentiate this patient from any other anesthetic assessment? And so I just say, in addition to like standard preoperative assessment, I would assess these things. And really in that context, I do my history investigation as I report these findings, and say at the end of that, CEC was going to report it to me. He wouldn't report everything as you asked. You'd synthesize it into, well, the severity can be based on the WFNS score. The stability could be really how acute is this, stable GCS, ABCs, cardiac respiratory stuff. I'm considering the causes, I'm considering the complications, and then where is this management going? And that's how I feel like I can get a really complete answer with context. And, I can just imagine this being, just one of those extra things. Like when you look at the Viva stems or the exam, like nothing in the stem of the short answer or the Viva is ever by accident. And just to be able to highlight certain things. So let's say you do have a subarach and maybe they mention an unusually tall patient, boom, you're thinking Marfan's, and then suddenly you invoke the high incidence of spontaneous pneumothorax, aortic dissections, mitral valve prolapse, induction abnormalities, or whatever it is. The other hereditary hemorrhagic telangiectasia, I just chucked in there. It is one of the potential causes or associated disorders, and it's really, really unusual for that to, cause a massive problem. I mean, so rare. I haven't seen one of these ever. Has anyone seen one of these cases, or patient with hereditary hemorrhagic telangiectasia? Not good. But if you have, please let me know. Complications of subarach. Chetan, what do you reckon? What are some complications of subarachnoid hemorrhage that you could just list off?
Two broad headings: neurological and non-neurological. Mm-hmm. In terms of neurological, again, there is always, because of the risk factor, it can lead to secondary brain injury. And the other complications are vasospasm, hematoma formation, hydrocephalus, rupture with associated bleeding. And the non-neurological ones are, and also, increased ICP in the neurological. Mm-hmm. And the non-neurological are, one is cardiac associated. It can lead to neurogenic cardiomyopathy. It can lead to changes in the ECG, which are suggestive of ischemic features because of the intense sympathetic surge associated with this condition. So you also can get T-wave inversion, ST elevations, which mimic MI. So I've seen many patients going for a cath lab instead of having a CT scan and then having heparin and then worsening the situation altogether. It can also lead to respiratory issues like ARDS, acute lung injury, pneumonia in long-standing cases.
Great.
It can also lead to neurogenic. Sorry?
Yep, cardiac stuff, lung stuff, any other stuff.
Yeah, so neurogenic pulmonary edema comes in respiratory. Then there's endocrine issues, which can again be DI. 50% of the patients have central diabetic insipidus. They can also have cerebral salt wasting.
Fantastic.
And hyperglycemia.
Now, remember this whichever way you want, but I like the fact, first of all, that you rapidly move through. There's the neurological stuff and other systemic stuff. Neurological, reread, vasospasm, cerebral ischemia, infarction, epilepsy, hydrocephalus, and then medical things include myocardial dysfunction, electrolyte abnormalities, and then neurogenic pulmonary edema. That's good. Now, each of these obviously has a lot of extra information, but this is where, yeah, these are my headings before I list the answer. Again, as a matter of technique, I really like your technique, Chetan, because you gave me the list before the detail. You gave me the headings before the detail. Andrew, I might ask you this question. The CKMB is elevated pre-op with some minor arrhythmias and T-wave inversions. Do you postpone or proceed with your clipping, your early clipping?
Which Andrew layer?
Hi, because you spoke up, it's you.
I guess from my perspective, is this something new, or is this something
It's
that
definitely new.
existing? Okay. Is there any hemodynamic instability from this?
No.
And what is the and this is surgery in terms of stopping the subarachnoid bleeding, so this is potentially a very life-saving procedure. I would definitely like to assess the severity of this and what's the potential repercussions in terms of cardiac hemodynamics.
And I see where you're going here, Andrew. You're saying the correct things. Let's say the hemodynamics are all fine and the clipping should happen. Surgeons want to do it early. There's also the possibility of late clipping. What's going on here with the heart, and how are you going to make your decision? Because we want you to get to a decision as quick as possible.
So I think if this is emergency, has to be done, then we have to proceed and we just have to manage.
I mean, it's not emergency. They could do a late clipping. And are you happy to go ahead with the CK rise and the T-wave inversions?
Not really, because, well, we're going to exacerbate potentially the situation. So therefore, it all depends on how urgent this procedure is. If there is late clipping, as you said, then perhaps there is some time to work up and see if there's anything we have to optimize physiologically before we proceed. And
I guess what you're worried about, what do you think is causing the T-wave inversions and the CK rise?
So I'm not quite sure how that's associated with the subarachnoid bleed. I'm wondering if something that's neurogenic.
You're good.
A stress response.
You're asking the right question. Because normally, if this was another patient, not a subarach patient, what are you worried about?
From the cardiac perspective?
Correct, yeah. CKMB, CK rise, T-wave inversion.
Oh, that you're wondering if this is a STEMI?
Exactly, right.
Yeah,
and
ACS.
In this 40-year-old female having a subarach, is this due to atherosclerosis causing some kind of acute coronary syndrome? Is that what's happening?
Probably not. There might be an association, but it's probably associated with the subarachnoid bleed itself.
Brilliant. So the subarach has caused this, therefore, in most circumstances, it's okay to go ahead. So this is a kind of a classic situation with subarachs. 50% of patients will have a rise in CK, but not usually consistent with MI. There's very little correlation between ECG abnormalities and ischemia. Maybe 0.7% will sustain an MI, and that will be a different pattern of presentation. So you'll do everything that you mentioned, like monitoring. You might try to get an echocardiogram, see what kind of dysfunction occurs, but you could also get that information from many other things, essentially presentation, hemodynamics. And then delay of surgery must be balanced against the risk of rebleed. In most cases, so this is straight from Artusio's Anesthesiology. In most cases, the balance is in favor of proceeding. This will, like you mentioned, so again, in this exam, you'll get this tricky situation. There's a difficult decision. This exam is about making decisions where things just don't seem ideal. And having information is knowledge is power, okay? So this is kind of a classic situation that, that's now it's useful to know. So so let's take that as a subarach patient without any other past history who's hemodynamically stable with some ECG changes. As mentioned, this is not really, this is a classic situation where you probably would go ahead. Let's change the situation slightly. What would make you, Andrew, what would make you delay this case? How bad would the heart have to be? Like, can you construct me a hypothetical?
Well, if the cardiac function itself, if there's any instability that's shown from hemodynamics, that is going to be a lot more severe than expected.
Yep.
And I'm worried that by going through a GA, that's going to exacerbate things. I will definitely have to reevaluate the situation.
So as soon as you get someone with instability, so specifically if they've got heart failure, they get APO, they've got malignant arrhythmias, or anything kind of pretty scary like that, then this is now the situation where I'd delay. Or maybe they've got ST elevation, they've actually got some signs of serious cardiac dysfunction. So severe cardiac dysfunction is about 2.9%, and which resolved over 4 to 5 days. So tricky decision, not ideal by any means, but most would be in favor of proceeding. And then knowing where your hard line is when you probably would postpone. Any questions about that?
Lairo, in terms of coiling or clipping, it needs to be done within 72 hours. So would you really delay things because of malignant arrhythmia, or just treat the arrhythmia and then take them for the procedure? Thank you. Yeah,
so it's been a while. I mean, the last time I did subarachnoids was back in 2012. Back then, we were still doing early and late clippings. If anyone's got any further information about this, I understand that I think a lot of times we do go early just to sort out the pathology. But if I had, I think it's kind of obvious, if I had a really massive problem with ST elevation, APO, malignant, I would try to optimize that over the next 24 to 48 hours and see stability, then talk to the neurosurgeons, and then we go ahead. But generally speaking, it's, subarach hemorrhages aren't, I need to go to surgery right now. It's not like a ruptured AAA. So I think I'd try to stabilize as best as possible, knowing that there's always the later clipping option. Maybe someone's worked in a neuroanesthesia center more recently. Please let me know if there's more information that we need there. So early or late surgery, so when it's within 48 hours of the subarach, the advantage is that decreasing rebleed risk. You facilitate the treatment of vasospasm, because now if you've got a clipped or secured aneurysm, you can target hypertension, and also just getting it done quicker means avoid complications due to a lengthy period of bed rest. But disadvantage, increased risk of intraoperative rupture because there's less time for clot organization and potentially poorer operating conditions. So brain edema and mild degree of hydrocephalus is common as well. So what are your intraoperative anesthetic goals? So say you get asked that kind of very broad question, what are your intraoperative anesthetic goals if you're doing a general anesthetic surgical clipping in theatre? Broadly speaking, what do you reckon, Luke? Broad goals.
So my broad goals are maintaining an adequate cerebral perfusion pressure, and more broadly speaking, then having excellent hemodynamic control. I'd want to maintain optimal surgical conditions. This patient needs to be incredibly still for safe surgery. I'd want to prevent seizures or identify and treat seizures if they were to occur. I'd want to have increased monitoring and intervene early if there were any of the other complications of a subarachnoid hemorrhage, such as the cardiac complications that we've spoken about already.
And you said excellent hemodynamic control. Why is that?
So these patients are at high risk if they either have hypertension or hypotension. So hypotension can result in a low cerebral perfusion pressure and more ischemia, and hypertension can increase bleeding and secondary injury as a result.
Yeah.
And there's also probably some moments during the surgery as well. So intubation, extubation, pinning, surgery and clipping that are the critical points.
Beautiful. Now, everything you said, absolutely true. I make very specific mention of the preventing rebleed as its own thing. And why that is, it's a 50% mortality, maybe even up to 70% right there. So there's no other event in subarachnoid surgery that has that kind of mortality. So I agree with everything you said. Maintain CVP, steroid oxygenation, optimize surgical access, and I mentioned rebleed very specifically because of that kind of serious risk. And it's kind of what you're saying, optimize hemodynamics specifically to prevent rebleed. but also maintaining CPP. Good. What is your preparation prior to induction? Yeah, so as a lot of you will know, I think there's so many things you could talk about with your preparation for, say, an induction of this patient. Just to get you guys talking again, Ash, what's your preparation specifically for a subarach GA?
I would want base pressors available so we can control the hemodynamics very carefully. Mm-hmm. Muscle, I don't know if this would consider as useful preparation, but nerve twitcher to make sure that they are adequately paralyzed for the surgery, BIS monitor.
Yeah. Hey, just the way you're answering that. So because you want to get as many marks as possible to finish the to say nerve monitor to monitor nerve, like I would just say the things you want to do rather than give it too much detail at the start, because you want to get lots of ideas on board. So yeah, go for it. What's your usual prep? Oh, sorry, what's your prep specifically for a subarach?
Also remifentanil. What else?
No, that's good. What are your categories? Like, how are you thinking about this?
So yeah, like surgical. Okay. So that would include the muscle relaxant, remifentanil, hemodynamics. So like arterial line, your vasopressor infusions.
Good. Okay. Now I'm thinking the category that I often use is something probably like monitoring assistance, drugs, and equipment. Yeah. And then you can have surgical issues aside from that if you're going to kind of use that, because then you can quickly go, look, I'd use my standard preparation, but additionally for monitoring, I want an art line. Absolutely. So that's monitoring assistance. I'd need a trained technician, but I wouldn't need too much more for that. Drugs, I'd have my remifentanil, propofol for induction, and paralytic, big dose of rocuronium, and then any extra equipment. And you could say whatever you need for pinning the head and for doing your local anesthetic for your what is it, your supratrochlear supraorbital blocks. Good.
Lehiru,
so, yes.
What is Mabel's?
Oh, sorry. Mask, airway, bougie, ETT, laryngoscope, suction. I just put that there because for completeness, if I was doing a short answer question, it just helps me say that this is all my checks beforehand. But let's say in the Viva and in the short answer question, I really just want to target the points of difference for this patient. Yeah, I've been really broad with that question, just to, I guess, highlight the point that you don't want to say all the normal stuff. You really just want to hit the stuff that is going to be very different for this case. Okay, let's say you've got this patient, hemodynamically stable, otherwise well, 50-year-old female who's 70 kilos. Ash, what literally do you give for your induction?
I would use a high dose of fentanyl or another opioid. I'm going
to give you all the information you need, but I want you to not give me anything that's vague. Give me doses and not mics per kilo. You've got to give me the drug and the dose and the system.
What was the weight of the patient?
Let's say 70 kilo, 50-year-old female, grade 3 subarach, hemodynamically stable, resuscitated, ready for surgery.
Okay. I would use 300 mics of fentanyl, 120 milligrams of propofol, and 70 of rock.
Okay, good. It's funny that you said fentanyl then, but you were talking about remifentanil before. What made you change to fentanyl? Again, not a problem.
I guess a bit more comfortable using fentanyl.
Sure. Now, what is the disadvantage of fentanyl in this particular case? So examiners might raise their eyebrows at fentanyl versus remifentanil.
Is it the risk of like hypotension?
Risk of which one? Hyper or hypotension?
Hypotension with the fentanyl versus...
Which is more risk of hypotension, Remi or fentanyl?
Oh, I guess Remi would be. Remi, okay. Yeah.
I'm going to say again that what is your highest mortality event badness that could occur in this case?
That you could that they could have a cardiac arrest.
That is absolutely true. You know the rebleed risk.
Yeah.
Rebleed occurs 50% mortality right there and then, and that risk is really high at induction. Therefore, what would you do for this induction, aside from every other emergency induction, to make sure you didn't get a rebleed?
So that you don't want them to become hypertensive at laryngoscopy.
Exactly. So what drugs are you going to give for that?
So instead of fentanyl, give remifentanil.
Yeah, I mean, I think a lot of people will either give alfentanil or remifentanil. Again, there's no absolute right answer for this. If you're going to give fentanyl, you have to give it early. The patient's probably unfasted, so you'll have to even wait longer time to make sure that fentanyl's worked. I think most people would give alfentanil, but let's just get a show of hands from the audience. For this induction, I think most people would use propofol and rocuronium of succinylcholine, I imagine. So I'm just going to assume that. Who would use alfentanil, for example? Put your hands up. Good. And who would run remifentanil for the induction? Okay, cool. So, you know, I would encourage you, just ask your consultants and your other colleagues, what would you do for induction? Everyone will have their method. I often said alfentanil just because it was easier for me to titrate that rather than run an infusion and bolus remi. But again, totally good to use either one of those. Like, you know, just get used to it. So my priorities are for induction, prevent the rise in transmural pressure gradient, which I've abbreviated there, that causes a rebleed. That's my worst event, but I also want to maintain CVP and cerebral oxygenation. So in my mind, hypotension in this patient for a couple of seconds is my preferred evil, whereas hypertension, that instance, if it goes up to a really bad number, could cause a rebleed. So I would rather err on the side of more in this particular case, and then slowly titrate up with some metaraminol if I go overboard, then get that, you know, super hypertensive response to laryngoscopy. So I've just said here, you know, I haven't given an amount there, but yeah, you know, I'd give easily 1,500 mics of alfentanil, if not 2 milligrams, 200 of propofol, 100 of sux, or 100 of rocuronium. And you know, 70K patients, sure, give 70. You know, there's going to be a long case. I'd just give the full 100. Realistically, I think a lot of us would. And then I usually have a bit of lignocaine in the propofol anyway. The fact that I really care about the problems with hypertension means I'm just going to add the fact that I'll have ESMO already in case the blood pressure does go up. If this is a difficult intubation for whatever reason, suddenly my blood pressure is going to go up from tricky laryngoscopy. That's practically what I'd say, and that's practically what I do as well.
Would you say, like, to answer this question, let the priorities bit first? Yeah,
look, it really depends on the exams changed a lot. Like I suspect that you just want to, if they just ask you, what do you want to give? If it's a very casual, what do you want to do for your induction? I'd just say the stuff. But I would mention, look, the reason I'm doing this is I really want to avoid a rebleed. That's my absolute priority here. Yeah, I think that's how I'd approach it. I really want to prevent a rise in transmural pressure gradient causing a rebleed. I would use 1,500 mics of alfentanil, propofol, big dose 100 rocuronium, and have ESMO already in case of a hypertensive or tachycardia response to laryngoscopy. That's probably how I'd say it. I'd have the real big extra thing for monitoring would be an art line, and that's pretty much it, I think. Does anyone have an induction that's substantially different? It'd be good to, again, there's many ways you can do this.
Lairu, what about spraying the cords with lignocaine at laryngoscopy? Would that be beneficial in terms of it would avoid post-op coughing and again increase in ICP, and at the same time it would it would prevent the hypertension and the associated increased TMPG at induction too? Yeah, what's your views on that?
That's completely fair. I know lots of people that probably would do that. As long as it's in the realm of what some people would do, there's no one amazing magic bullet for anything. But if you were to say that, I would not disagree with you. And I mean, to answer your question, that sounds completely reasonable. Doesn't sound crazy. Does it always work every time instantly and also last till the end of the case? I don't know. Sometimes it does, maybe it doesn't. But I think that's completely fair to say that. So, one of these tricks with this exam is like, for most of your training, people have told you how important fasting is and, and aspiration risk. And the fact is that a lot of these emergency cases like this, you will want to do it you'll have to kind of do this modified rapid sequence induction, but also the point that this isn't, the risk of rupture is so much worse than the risk of aspiration in these cases, that if you needed to take longer with your induction, you would err on the side of that. So I think that's one of those things that as I went into the exam from a junior level was that, aspiration seemed like such a big deal when I was a junior, and suddenly in these emergency cases or these tricky cardiac cases where you don't want to suddenly give a massive dose of induction agent, where you kind of want to titrate your drugs, like say you're running REMI, you might give your propofol, run the REMI, make sure your heart rate's down, like you're just taking a little bit longer than rapid sequence. So this was just one of those things to know that I've got some stats to back the fact that I don't need to rush ahead with this if I'm really worried about an unsecured aneurysm. Okay, what are the critical times during the surgery? I might move on to the other Andrew. What do you think? Yeah, critical times where things go wrong. Other Andrew. Hey, Andrew, what's your surname?
Rabinovich.
Oh, excellent. Yep, that's right.
Sorry, I'll try and put in my name. I think so. Some of them we've already talked about. The obvious ones are induction, Mayfield pinning, time of actual clipping of the aneurysm.
Yep.
And extubation.
Fantastic. There's another one that occurs that suddenly changes the transmural pressure gradient. And actually, what is the transmural pressure gradient?
So it's the pressure, it's the difference in the pressure between inside the vascular structure and in the cranium.
Yeah, and so the inside, we've talked about, any kind of sympathetic response causing blood pressure up increases the TMPG. What would be on the other side of that?
Yeah. So at the time of the craniotomy.
Absolutely.
So when you first open the cranial vault.
Perfect. And I think I'm pretty sure this was part of it, SAQ or something like that. But yeah, induction, pinnings, incision, dura opening, hematoma removal, and clipping and extubation. So these are the critical times. Andrew, how do you prepare for these critical times? I think again, this was an SAQ. I want you to go as broad as possible. How do you prepare for these critical times? And actually, you know what, everyone, maybe take a minute, everyone write down just some points, go really broad, because that's how you get as many marks as you can. So take a minute to do that.
So I've just written down a couple of things. Obviously, I barely started studying, so there won't be much structure to this. But the general things I was thinking of are appropriate communication with the surgical team, your positioning relative to the patient, and your access to, I suppose, knowing what's going on, and timely delivery of drugs. As an extension of that, what access you have to the patient, and making sure you've planned ahead with what particular drugs you need at these critical times, so that you're ready with them, essentially.
Any other ways you could say make sure that the patient was analgesed enough?
And beyond looking at the usual sort of signs for analgesia in terms of hemodynamics
yeah, good. Anything you could do? Any drugs you could give?
Like preemptively, you mean?
Yeah, I think so. Yeah.
Yes. So obviously multimodal analgesia, and then time, as I said, sort of preemptive administration of, for example, in the Mayfield pins, obviously, if you're running REMI, then a bolus of the REMI, or a small dose of alfentanil or something else. As it depends on what the moment is and what you're trying to temper, but essentially being ready with the drugs and timely administration.
Beautiful. What else could you do to prevent the pain response of the pinnings?
There's
some very specific.
I'm not sure.
No, that's right. You've only just started studying. I remember when I first got this question, I was like, wow, they've really gone broad with this. I actually really like the fact that you mentioned the communication stuff. Like, absolutely put that in. In adequate monitoring, you want to know at time 1 second when the blood pressure is peaking. Adequate depth, adequate paralysis, with neuromuscular monitor, analgesia, remifentanil, nerve blocks, and then a whole bunch of medications to prevent whatever occurs happening if it becomes a sudden hypertensive response. Yeah, good. Again, any questions with that? Feel free. What else? Let's go with optimizing surgical conditions. Like, this is just like a very specific question about, if you have a tight brain or whatever. I want you to everyone write down some categories first of all, and then some notes just about how to prepare for, how to optimize surgical conditions. Yep, take a minute. I might ask at the end of that. Hey, just hands up, who is sitting again?
I'm happy to do one here.
Yeah, go for it.
So I was thinking like access, immobility, and sort of visibility with the headings. And from access, I was, your tubes, monitors, lines away from the surgical site. From immobility.
That's actually great. What are your tight brain stuff?
Oh, sorry. I think I was going more broadly. You want for this case?
No, but that's actually good. I like that you went broad, because that's all true statements. And now, because let's say I'm examining you, oh, that's great. Full marks for that. Tight brain. How do you optimize the swelling of the brain or whatever?
Okay, sorry. I think I was going down a completely different path. So tight brain, you can optimize it by reducing the things within the cranium. So blood, you want to assist venous drainage, head up 30 degrees if it's feasible, preventing ties around the neck, reducing the intrathoracic pressure. You can reduce arterial blood volume by hyperventilating the patient, aiming for low normal CO2. You can reduce the brain volume if needed by giving drugs, mannitol, hypertonic saline, sort of more in the emergency situation. And you can, what else am I thinking of? Things like, adequate depth of anesthesia and paralysis also help reduce the brain volume. Mm-hmm. What else? What have I forgotten?
Anthony, that's really good. So on the spot, you actually gave a really, really good complete answer. So I'm going to kind of nitpick here now. You mentioned CO2 affecting blood volume. Absolutely correct. Any other things that you could, any other physiological parameters that you would also mention?
You want to aim for normoxia, normothermia.
Yep. Anything else?
I'm drawing a blank.
Oh, that's good. How about blood pressure? What are your blood pressure aims?
Oh yeah, of course. Yeah. So you want to maintain a cerebral perfusion pressure without sort of being hypertensive. So you want a cerebral perfusion pressure of sort of 60-ish. Assuming an intracranial pressure of 20, sort of aiming for a map of about 80. Yeah,
good. Now, it's a really interesting thing that when you have a normal patient's brain non-anesthetized, you've got that autoregulatory plateau, like between 60 and 160. Between 60 and 110 or so. Now, within that range, as the blood pressure goes up, your autoregulation means your blood volume goes down. But as soon as you give a GA and have trauma to the brain, suddenly the higher the blood pressure goes, you're not really sure where the autoregulation is sitting. So the higher you go with blood pressure, the more blood volume there is as well. But you mentioned other things. Normothermia, hypoxemia is terrible. So keep it normothermic, and also blood sugar levels. The way I found that this was useful was, so Monroe Kelly doctrine was a great way, one fantastic way of thinking about it to make sure I got all the answers. But then that was for my first part, but for my second part exam, I actually found that this categorization, positioning stuff, pharmacological and physiological, was more amenable to what I'm about to do at any time. And I think you went through that as well, because you told me about head up, loosening ties, collars, PEEP, intrathoracic pressure. You literally just mentioned those things. And then we went on to a few other stuff, which you combine, as you mentioned, pharmacological and you mentioned physiological as well. So when I think of this, positioning easy, just what I can see. Physiological is my monitors and a blood gas, and that pretty much sorts that out. And then pharmacological, just knowing which doses of what I can give. Again, in the exam, like for a long time, there was this thing of avoid nitrous, which I think, I don't know if people are still mentioning that in their short answer questions, because, you know, rarely are we using that anyway. But yeah, this was just my framework. And then finally, surgical correction, which I haven't mentioned here, but on a future slide, which is, you know, what kind of surgical things, Anthony, could you do?
Surgical things to optimize surgical conditions.
Yeah, more surgical things, or to decrease ICP, let's say.
Yeah, I mean, obviously the craniotomy does that. I mean, a ventricular drain to reduce the
absolutely
the CSF.
And someone's just mentioned seizure prophylaxis to the list. So yeah, I think so. I think the fact that they've got, you know, I'm in the anesthetic context and I'm running volatile or propofol in a tight brain. I don't think of seizure prophylaxis because it just never happens in that situation. But never say never. I think being broad is useful, and I think mentioning seizure prophylaxis or checking that they're on seizure prophylaxis is probably useful. Okay, so, and there's essentially the context of it. So after the bone plate was removed, the dura is being opened, the surgeon says the brain is tight. What can you do to facilitate surgical exposure and decrease ICP? So essentially positioning, pharmacological, physiological, and then surgical stuff, CSF draining with an extraventricular drain. The surgeon says there's a sudden increase there's sudden increased bleeding. So the incidence of this is about 2 to 19%. That's a big range. It's hard to know what to take away from that. The stage of operation affects the outcome. So it makes sense at induction, your brain isn't open, it's not amenable to treatment straight away. So, you know, something goes wrong there, it's far worse. The first signs often is kind of Cushing's reflex, increased blood pressure, and then bradycardia. And the aim is to maintain CPP whilst facilitating surgical exposure. Yeah, so control hypotension, aggressive volume resuscitation. If a temporary clip is used to gain control of a ruptured aneurysm, return systolic blood pressure to normal to improve collateral flow. Hey, who's done neurosurgery kind of recently? Has anyone been an RMH recently? Grace, have you had a subarach where it's ruptured, or the surgeons have asked you for hypotension?
No, I haven't seen any ruptured.
Thank goodness for that.
Aneurysm.
If the surgeon does ask you, let's say they're in there in a clipping, and they say that there's a lot of blood, we need the blood pressure drop, it looks like the lesion's ruptured, what do? They want you to lower blood pressure.
So I would give adenosine as a bolus, and the dose is from 6 to 24 milligrams. So some people just say go straight for 24 milligrams. Stop the heart.
Would you give that as the first thing you give?
If they're like swearing, yeah. Okay. But so other things, like obviously what we've talked about, decrease your ICP, get their access better. If you just want to lower the blood pressure really fast, just give a bolus of your propofol and Remy. So just, and then if we had your esmol drawn up as well, you could give that 40 milligrams, or labetalol, similar.
Okay, good. The only reason I say that is, let's say, I totally agree, the level of surgeon urgency, whether they say fudge or whether they say the other word, it's going to make a difference to how much you respond to this. But that said, surgeons have all levels of vocalization, and a lot of them just, become very non-communicative.
Silent, yeah.
But yeah, what is on hand is propofol or thiopentone or whatever else you got in your drawer. Adenosine often requires you to get the emergency drugs out, but completely agree. The important thing is that there's only a few times, there's a few specialties where you really listen to them when they ask you about hemodynamics. So it's not ortho usually, but it is thoracic surgeons and it's neurosurgeons, because you kind of feel that they know the organ better than you do, whereas you never believe that of other surgeons. Like you believe that you know the cardiovascular system better than they do. So when they ask you for controlled hypotension or hypotension to sort a problem, you go, yep, whatever you need, let's do this, and you go in close communication. So that was for everyone who's hasn't come up against this circumstance, it always feels very awkward when the patient's bleeding and your blood pressure might be dropping anyway, and they want further blood pressure drop. It might be very awkward, but know that you've got to do it in some measured way, and the easiest thing to do is give propofol and do that for a limited period of time. Good, some great chat there. Manitold is normal cell hypernatremia anesthesia. So yeah, so again, I almost leave this a little bit in that urgent setting. If I'm asked to give mannitol, I just take that bag out. I think it's 200 grams, and I give 1 gram per kilo, or whatever dose that the surgeon recommends to give, because I just don't give it that often. Yeah, and then okay, good. So, and 3% normal saline. It's mainly mannitol that I've given. Has anyone given 3% normal saline, hypertonic saline recently, or at all? How much did they give, and how do they give it?
Only in an ICU setting they hear, and they usually go like 100 mils, and then because they're in the ICU, you kind of just monitor the response. Yeah.
How quickly do they give it? 100 mils of 3%?
Yeah. Okay. So there's a protocol that you should give it, I think, over 10 minutes. But honestly, I've just seen them give it as a bolus. But yeah.
Yeah. Good. The anesthetic 10 minutes. Love it. Good. So would you extubate the patient? What factors influence your decision, assuming normal airway, ventilation, nil other complicating pathology? So yeah, all the usual things. Are they stable from their ABC's point of view? And generally speaking, they talk about, the higher grades requiring mechanical ventilation, and the lower grades may not require intubation post-op. But then patients with vertebral and basilar aneurysms may require protection secondary to cranial nerve damage and loss of protective reflexes. Okay.
Sorry, Hillary, that's an interesting, I've never seen that before, Hunt and Hess being associated with your ability to extubate the patient. Is that just something you've seen, or is that sort of in the evidence, or is that something, because I'm like Grace, I honestly find Hunt and Hess really hard to wrap my head around, so I haven't really studied it, but is that one of the benefits of using Hunt and Hess, is it to delineate whether you can extubate?
I almost want to take out this slide because I feel like I've taken it from some article that was probably old and a long time ago. What would influence your decision? If someone's asked me this question, I would literally just go, higher grade aneurysm, likely GCS fluctuations, difficulty protecting airway equals intubation, providing everything else, and lower grades with likely GCS recovery, I would try to extubate. I think that's how I'd go with this, irrespective of Hunt and Hess. So this could be World Federation with low GCS. Yeah, I mean, 4 and 5 is what, GCS 7 to 12. Yeah, I think I'd go on an individual basis, and that would be my logic. Does anyone have another approach for this? Good. So Luke has mentioned high Fisher score equals higher risk of vasospasm in further management. So I think Luke is saying there that if you've got this high risk of vasospasm, really you want to be able to, I mean, there's lots of patients with high risk of vasospasm who are extubated, and that allows you to diagnose this because they've suddenly got a focal neurological deficit as well. Hey, Lucas, are you able to talk about that? High Fisher being, as in vasospasm being your decision to keep them intubated? If you could type that out, that'd be great. That's an interesting point. In the meantime, I want everyone, like, failure to wake post-anesthetic, such a great general question to get for any surgery. And I remember whether it was ED or on the ward, decreased conscious state was just that really annoying thing in terms of the broad range of differentials. But there's a method to getting your answer quickly. So everyone, just in the next minute, write down their approach. And at the end of that, I might ask Emily. Okay. So just before I ask Emily her approach, we've got some good discussion here. So I think Chetan's point, if you've got an ETT at the start of the case, ETT remains at the end of the case. I think that's really reasonable. Like, suddenly having an improvement of the ETT is probably in because of some kind of instability or decreased GCS, and the chance of it recovering rapidly post surgery is probably unlikely. And there's, what's the rush? So that's, I think, a really good little rule there. And Lucas has also said if they're going to need high dose NORAD, so yeah, you've got this likely complication which needs some, decent management with NORAD, calcium channel blockers, maybe even potentially going to radiology, it is just easier to have this patient intubated without that as a constant incident that's going on. So yeah, I think that's a really good idea. And often a lot of these things are in discussion with the surgeon as well. I think I'd clip instead of coiling, lean towards leaving it in as well. Yeah, I think if clipping instead of coiling, leaning towards leaving it in as well. Excellent. Emily, what's your approach to failure to wake post-anesthetic in subarach?
So my priority in this situation is to maintain the physiological and psychological safety of the patient whilst rapidly assessing for and then managing potential causes of the failure to wake. And so what I mean by maintaining physiological and psychological safety is maintain full monitoring on the patient and to talk them through what I'm doing and provide reassurance that they're safe. In terms of assessing for and managing the potential causes, I want to rule out the simple things first. So make sure that my anaesthetics are all turned off, that I have reversed relaxant, which I would assess via a neuromuscular twitcher. Reviewing my anaesthetic chart, particularly the doses of opiates or any other longer acting sedative agents, and I could consider a reversal where there is one available. So for example, small titrated doses of naloxone starting at 40 mics. And review response. I would want to exclude a hemodynamic cause of their failure to wake, so to make sure I have adequate blood pressure, as well as excluding hypoxia or hypercapnia or another ventilatory cause of their failure to wake. So I could do that with an ABG and review of my ventilation settings. Another consideration would be drug interactions. So for example, like a serotonin syndrome or a neuromuscular malignant syndrome, although I would expect probably a more agitated presentation in that sense. Having excluded the simple things and treated for the simple causes of failure to wake, if I still haven't found a cause for this, I would be maintaining general anaesthesia in this patient to ensure their psychological safety whilst doing more, I suppose, invasive or time-consuming investigations, which would really be brain imaging at that point.
Yeah, good. Now, Emily, so the great thing is that you're so eloquent that you just kind of keep talking and you don't say ums. I feel like because you're more eloquent than what I speak at, I need to categorize things. And I think your categories were perfect because you just went through it and you got to a lot of detail and got the answers straight away. So for me, I rule out physiological, pharmacological, and other causes, and then I try to speak like you and get through all of that stuff. And if anyone, I forget if you mentioned, I'm sure you did, I always take a venous gas for physiological because that gives me almost so many of my differential sodium, blood sugar levels, and if there's any other derangements. And exactly as you said, go through all of your anesthetic stuff because that's always going to be the most likely cause of this problem. You know, I've just put local anesthetic CNS spread because there's certain cases where you might have an eye block or something and it's just gone into the wrong spot, or a high spinal or an epidural in the wrong spot. So I always think about that as well. And then all the weird and wonderful things where you essentially have to go to CT to get a diagnosis. But good. Does anyone have any different methods for failure to wake? Anything that we may have missed there? Good. Spot diagnosis. Luke Garbett, what do you think is going on? Subarach, day 4, disoriented hemiplegia?
So this is concerning for a new intracranial neurological process. Rebleeding would be high up on my list of concerning and high-risk differentials.
Beautiful. If there was
vasospasm as well.
Beautiful. So let's go vasospasm, clinical diagnosis really with altered conscious state and focal neurodeficit. What investigations do you need to do for that, Luke?
So I'd firstly want to optimize the hemodynamics and then arrange for safe transport for formal diagnosis, which I think would be a CT, but possibly MRI as well, or a combination of both.
Yeah, great. So CT is often normal. Transcranial Doppler can show increased cerebral arterial flow velocity, and angio is apparently gold standard, but yeah, 60% will have vasospasm and only half will have the neurodeficit. So there's obviously a gap between a gold standard investigation and what clinically occurs. Hey, so again, maybe take a minute, everyone, just write prevention of vasospasm. If that was your question, how do you categorize it? What are your broad things that you need to address? So take a minute, and I might stick with you, Luke, for that answer.
So maintenance of euvolemia, a systolic blood pressure of 120 to 150, and then potentially a role of nimodipine would be the three main therapies. Classically, I think it's a bit outdated now, as there was the triple H therapy.
Yep.
But this, and I think more broadly speaking, management in a neuro HDU, IV access, either oral or IV fluids or a combination of both, having an IDC in situ to monitor that, and regular fluid assessments and daily weights can be useful as well.
Sounds good. Tell me about nimodipine.
So nimodipine is a calcium channel blocker, and the idea of its use is to cause vasodilation, specifically in the cerebral vessels, or prevent constriction through that same mechanism. And it's just a bit more selective, I think, for the cerebral vessels rather than the other peripheral vessels.
Yep. Evidence, dosage.
They give it every 3 hours. I'm not sure how much. I'm not sure.
That's right.
I think that it's definitely given in high risk cases, and it can either be oral or IV. Beautiful.
Who can give me some information about nimodipine? It's common enough asking about dosage and stuff. Anyone can jump in.
The dose is 60 milligrams oral 4 hourly. If the patient is conscious enough to have it, and if the patient is not conscious enough to have it, then it's 2 milligram per hour as an infusion.
Fantastic. Where's the evidence for IV or oral?
No, not sure.
No, that's right. Yeah, it's apparently only evidence-based for oral, but that's absolutely right. And nasogastric also potential. So 60 milligrams 4 hourly, and start day 1 and continue for 3 weeks, or 1 to 2 milligrams an hour IV. No proven effect on reducing angiographic evidence of vasospasm, but does improve outcomes, possibly cytoprotective effect rather than one of vasodilation. And it's really good that you went broad with that, Luke, because hypervolemia, people aren't aiming at hypervolemia. They're not aggressively hemodilating, and the hypertension is, more of a reasonable level of hypertension for preventing it as well.
Is the nimodipine for everyone? Like grade 1 still gets nimodipine?
Let me think. I'm not sure of the answer to that. Anyone got an answer there?
I don't think so. I think there are some patients that they don't give it to.
If someone could Google, I'm sure there's an article that talks about low grade and nimodipine, and a lot of, I just haven't worked in the center seeing that it's being given for everyone or not. Sorry about that, but I'm sure Google will tell us an answer. Please let me know if you come out. And so prevention, again, I've got a few things for treatment here, but normal stuff, normal CO2, normal O2, BSL range, careful monitoring, and there's no evidence for routine use of antifibrinolytics, steroids, or anticonvulsant prophylaxis for Subarachnoid. And just to go through these trials, just to kind of, again, in my exam, I don't think I was asked, I wasn't asked about a study or trial once during any of my 8 vivas, but these are pretty relevant to this. So the ISAT trial talked about coiling, decreasing risk reduction by 22% absolute risk, and absolute risk by 6.9%, sorry, relative risk by 22, and absolute risk by 6.9%. And the survival benefit continues to 7 years with endovascular versus clippings, but there was a sample bias. The 31% suitability for coiling is lower than usual, and the clip group had a 50% higher pre-op bleed rate. So the clip group did much worse than comparable centers. So, obviously there's a lot of problems with any of these trials, but just to be able to talk around this is useful. And then the IHAS trial, so mild intraoperative hypothermia during surgery for intracranial aneurysm. The conclusions were intraoperative hypothermia did not improve neurologic outcome after craniotomy among good grade patients. So that is, grades 1 to 3. With the subarachnoid hemorrhage, so really just those 2 trials, and the criticism's not cold enough and not done early enough. And just to go through coiling, so you've got these coils. Essentially, a microcatheter inserts it via the femoral artery until inclusion of the aneurysm is achieved. Better 1 year and 7 year survival, but risk of late rebleeding. And so pre-op's a similar workup. Intraoperatively, you just got all the issues, the fact that this wasn't apparent to me before, doing these cases, but besides being remote and having to deal with radiology and radiation and contrast, you've also got heparinization. And so you got to think about that in this context as well. So, hey, Grace, I might just ask you about this case. Let's say you've got this 40-year-old female for coiling of a grade 3 subarach. So you're in radiology for the coiling. Let's say they're otherwise absolutely fit and well, no allergies. And you're in the angio suite, remote to theatre. The patient's intubated with volatile and REMI running. Outline is already there, 16 gauge in the cubital fossa, which you have access to. The interventional looks suddenly distressed. What do you do? They start swearing.
Yeah. So I'd like to open up some communication and just see what their concerns are, as well as scan my monitors and check that the patient is stable.
Excellent. And if you were to, because this particular surgeon or radiologist just isn't very communicative, what things are you going to ask very specifically is going on?
Have you ruptured a vessel?
Mm-hmm. What's the other one? What's the other problem? Is it either a rupture or?
Not sure what you're thinking.
No, that's right. You're sticking stuff into something. It's either rupture, you blocked something off, which shouldn't be blocked.
Okay.
Let's keep going with that. So let's say that the surgeon says, yeah, it's a rupture, and we're trying to control this bleeding. What do you do?
So I'm in radiology. I'm off the floor away from help. So I'm going to press the buzzer and let my anaesthetic nurse know as well. And we are going to try to reduce the ICP as rapidly as possible. So I'm going to hyperventilate the patient and aim now for a lower CO2, maybe 25 to 30, and optimize all my other physiological variables, as well as give mannitol, 0.5 grams per kilo. I'm also going to activate a massive transfusion protocol and ask for cross-match. We'll get some blood, basically. And hopefully by now I've got some more hands to delegate some of these tasks. So my aims are to prevent, so it's a bleed inside an enclosed brain. So compared to compared to a clipping where the brain's open, our issue is the raise in ICP. And usually the interventionalist can get some kind of control intravascularly, but we'd also want the neurosurgeons to be aware of this happening and see if they're available to come to radiology and assess whether or not this patient would be amenable to an open repair based on their anatomy, because that would be our backup plan. And that would also involve notifying theatre.
Yeah, excellent. So what I really liked about your answer is you're targeting very specific things and you're anticipating, and you're kind of telling the full story of it. So instead of saying just that I'm gonna, try and decrease the ICP, but you're also saying, look, this might be ongoing bleeding, therefore I need to prepare for that. This might be something that the neurointerventionalist can't fix, therefore I need to talk to a neurosurgeon. So you're telling the full story of this very quickly. And that full story can be said very quickly and then colors the whole scenario in, which I really like. So yeah, so I first ascertain whether it's occlusive or hemorrhagic. I call for help because you need lots of hands for this. I optimize all my ABCs, but essentially 100% oxygen and have good IV access, which you do, and then prepare for urgent transfer, as well as managing the fact that you need blood bank and a whole bunch of people for this, and any specific management. Yeah, good. So if it was vasospasm, withdraw catheter and intraarterial nimodipine. If it's rupture or hemorrhage, then if this was an open situation, you might have to decrease MAP, decrease ICP, and give protamine as well if they've given heparin. And if it's occlusive, you might need to give, do hypertension to try and provide a collateral blood flow. And yeah, so the proceduralists may need to do whatever they need to fix that problem as well. But there's very specific problems that could occur in this situation. So intracoronary vascular lesions, what is this in a nutshell? So, well, I mean, the way I think about it is just a craniotomy plus strange positions, major bleed risk, and venous embolism. So whatever I thought for craniotomy, I'm just going to add on these problems. And that's the way I kind of address this. So what are the key steps for rupture management? So again, a lot of the usual stuff, but just as we mentioned before, after you get your help and you're managing ABCs, you may need induced hypotension. And the easiest way of doing this is with, propofol, thio, pentone, voltaren, remi, labetalol. And then after that, you need fluid and blood, because there's just a whole bunch of blood that can be lost in this. And then also this comes with a carotid compression or a temporary clip as well. And so you'll notice that, again, one of the strategies I had for this exam was trying to bundle various things. So when I think craniotomy, that's a thing that I've memorized. When I think of positional issues, that's a thing that I've memorized. When I think of bleed risk, I'm thinking about massive transfusion and all the things that involves, and hematology and blood bank and cell saver and rotem and how to read that and how to replace factors and products. And then again, venous air embolism, that's its own bundle of care as well. And so if I've got all these little bundles of how I, remember stuff, then I just have to mix and match them and hopefully get some decent answers out. And then post-op hyperperfusion, cerebral edema, and increased ICP, with general stuff there. Yep, so AVM clipping and posterior fossa sitting in the sitting position, consultants getting coffees, and suddenly the patient becomes tachycardic with an end-tidal CO2 drop down to 10 millimeters mercury. Okay, that's pretty low. Does anyone want to tell me what they're really worried about with this, first of all? You can jump in anytime.
Venous air embolism.
Yeah, sounds good. Now, I haven't picked on someone. Hey, Edward, did you want to talk to me? I forget if you're sitting the exam or not. Did you want me to ask you stuff on this?
I'm not sitting the exam.
Oh, yeah.
I don't got much knowledge to offer.
No, that's all right. Sorry, could people who are sitting the exam put your hands up again? I might as well ask someone who's sitting. Excellent. I don't think I've asked Anthony in a while. Anthony, what's going on? What are you worried about?
Sorry, what's the question?
Yeah, so
what do you do?
Patients has an AVM clipping, posterior fossa, so it's sitting position, and the patient suddenly becomes tachycardic with an end-tidal drop. What are you worried about here? What are your differentials? Is a better question.
Oh, the one to exclude, as Luke mentioned, is venous air embolus. I guess other differentials could be some sort of monitoring error or an airway issue. Yeah, like yeah.
Actually, monitoring error. Actually, keep going. Let's go some more differentials before we move on.
Okay. I mean, this is a sudden drop, so it's not going to be, it's not going to be like, yeah. I mean, I guess the other thing, the other differential could be a cardiac issue. So delivery of CO2 to the lungs.
Exactly. So what am I implying when I say the sudden end-tidal CO2 drop? What does that imply?
An event.
An event? What kind of event? Which system?
Yeah, cardiac or respiratory.
Absolutely. And it's obviously really, really bad. So what other really bad cardiovascular things could be occurring besides a venous air embolism?
PE.
What was that, sorry?
PE.
Yep, PE.
Pulmonary embolism.
Keep going.
Pneumothorax.
Yeah.
Like I said, a cardiac arrest or significant hypotension.
Look, I'd always mention anaphylaxis in this same sentence because it's such a common serious event that we get. Good. So you're considering those things. The surgeon's worried about air embolism. Okay, Anthony, what do you do to manage air embolism?
Okay, emergent. So from a quick scan of my monitors, I want to see, I've got an outline. I want to see I've got a blood pressure. See what my SaO2 is, and I'd flick it over to 100% oxygen while I'm doing that to temporize. It's an emergency situation, so I press the buzzer.
Just to give you information, the blood pressure is down to 40. And you see it is sinus tachycardia on the trace, end-tidal CO2 as I mentioned.
Yeah.
And the SATs are, it kind of, it's a low perfusion trace, and the SATs are like 93%.
Yeah, okay. So I press the buzzer, I'll tell the surgeons, alert them that I'm concerning for VA anesthesia, and get them to stop what they're doing, flood the surgical area with saline, we'll lower the head to below, to at the level of the heart. If it's feasible, it's often difficult in neurosurgery, have the patient right side up. Head down, right side up. If I had a CVP, you could aspirate the CVP. And then I would optimize the ventilatory setting, so high PEEP, and maybe try and hyperventilate the patient.
Mm-hmm.
I would make sure that they have adequate IV cannulation and be giving fluids to aiming for a high normal CVP. Just trying to think, is there any other specific treatments?
And so what is your, I found that venous embolism is, it's not a crisis with a few different ways of approaching it. And a lot of the stuff you mentioned is absolutely right. You're flooding the site with saline and, head down, and then you're giving 100% oxygen. Do you have a framework for each of these steps as categories by any chance?
Yeah, I was thinking as I was giving it, I haven't framed it very well. So yes, yeah, I should frame it in, I'm trying to, I'm trying to provide supportive management. So with the oxygen, 100% oxygen, I'm trying to limit the movement of air. I'm trying to keep air in the right atrium with positioning.
Mm-hmm.
I'm trying to prevent further air entering the circulation by getting the surgeon to stop flooding the field, and also lowering the surgical site. And I'm also trying to, I suppose, under the category of minimising air moving from the right atrium into the pulmonary circulation, I could put the other things like high normal CVP and higher intrathoracic pressures.
Yeah, good. Now I'll tell you, and that's, even though it was still a really good answer. Like, even though you didn't have the categories, you still gave a comprehensive answer, and you're moving through it pretty quickly. Now, so the way I'd say this is the kind of the obvious stuff. This is an absolute potential catastrophe. I'd immediately get help and tell the surgeons what we're going to do. And then I'd take it back a bit, because I know in real life, you got to kind of, get things going really quickly. In the Viva, I think it really helps to say my broad categories of this management is to prevent further air entry, which was the first thing you said, which is great.
Yep.
Decrease the size of the existing air embolism, and then supportive measures and promote forward flow. So I don't have to go through too much of that in more detail, because you prevented further entrainment with flooding the site with saline, dropping the head down as best as possible, knowing that they're in pins and it's difficult. And then decreasing the size of the air embolism, which was 100% oxygen, plus aspirating on the existing CVP if it was already there.
Yeah.
And then supportive and promoting forward flow. The reason I say that was, at no point, I think, correct me if I'm wrong, I didn't feel like you mentioned oxygenation as supportive, but really what I wanted to hear was that, but also metaraminal, adrenaline, CPR if required, because this is still a problem of cardiac arterial collapse. So, I'm pumping in fluids, I'm giving aramine, I'm giving adrenaline required, CPR required. Cool. So that's probably that. ABC approach, prevent further embolism. Even up till when I was training in a neurosurgery hospital, they used to have this thing where in some cases they would just put a tourniquet around the neck. So just to know that was a thing where as soon as you were worried, you would tighten that tourniquet to prevent further air entry temporarily, and then take it off. You'd also have the precordial monitors and things to listen for that, which is that mill wheel murmur. There's a really good CEA CCP article on this, which kind of goes through these categories. So I've got to credit. I just thought it was a really elegant system of categories for this particular problem.
I had a quick question. Sorry, I've read somewhere that cardiac compression, although there is no cardiac arrest, is still sort of given in this situation to break the air embolus.
Yeah,
make it smaller. Is it something worthwhile saying, or too silly?
No, and I'd say it in the way of if this patient had a cardiac arrest, there's a potential benefit firstly of cardiac compressions to promote forward flow, but also to break the embolism. That's probably how I'd say it. But I also know that really the solution to this, if they're still in sinus tachy, I can, and I've still got a blood pressure of 30 or 40, I really need to solve this problem. And that CPR limited will do some things, but really I just need to get more fluid in and promote forward flow and try to decrease that size of the ambulance as well. I think there's another question.
Sorry, Leo, I just missed when you said there was an article on this. What kind? Where was the article?
Yeah, the BJA education.
Beautiful. Yeah,
it's kind of old now. It's probably in the 2000s. But yeah, all those principles, lots of good stats, lots of good information in that article. I think it might be in the notes I sent, maybe. Anyway.
Awesome. Thank you.
No worries. Hey, so that's the Subarach and AVMs kind of stuff. So we went through Subarach. So many good exam tips in that. So that's why I just wanted to kind of spend a bit of time on that. So we've got the, the preoperative assessment stuff. We've got the how to, in addition to my usual assessment, in addition to my usual preparation, targeting the points of difference of those. We went through a couple of trials and then AVMs and just bundling certain things, and then a few crises as well and how to approach those. So yeah, subarach hemorrhage, just so rich with examinable topics. And, anesthetists love to think they're a bit medical. So lots of good medicine stuff as well. Okay, let's move on to head injury. Okay, 35-year-old brought in by ambulance, sorry for the abbreviation, to emergency with an 80-kilometer-an-hour motorbike accident versus car. What's your initial approach? And again, I might just ask, let's go. Luke, what's your approach to this? Luke Garbutt.
So this is a very high energy, high mechanism. So I have a high suspicion of major injury, and I'd start with an approach that aligns with the emergency management of severe trauma, starting with a primary survey.
Beautiful. After primary survey, what are you doing?
Well, as part of that, I'd temporize and intervene in any life-threatening measures, and then follow with a secondary survey, which will dictate further management.
Beautiful. I've said something similar. There's a trauma patient with a head injury, multiple. So I may have not mentioned that except in the title. And then EMST principle, first primary and then secondary survey. Great. So these are kind of the things we'll go through. Like really, the way I think about head trauma is really the EMST stuff, cerebral protection stuff, ICP and CPP management. So again, you do your EMST just to be able to go through all of this, as rapidly as possible. And then secondary survey really is your amble history, your head-to-toe examination, and then all your investigations. What investigations would you have in a secondary survey, Luke?
So I do a fast scan,
yep.
Looking for any free gas. I do a chest and pelvic x-ray, potentially an x-ray of some long bones, if it's indicated, and baseline observations where that falls into that category. Other useful things can be a venous blood gas or arterial blood gas, and a set of full bloods.
And in this particular patient with the head injury?
So ICP monitor, whether that you count that as an investigation, is a consideration depending on their GCS.
You may have already mentioned this, but CT,
right? CT trauma series, yeah.
Beautiful. So let's say this case is a 35-year-old motorcyclist, previously well ASA1, no allergies or meds, helmet broken on impact, in collar on the spine board. So these are the observations: heart rate 120, blood pressure 90 on 60, SATs 95 on 4 liters, Hudson mask, then moaning incomprehensibly and combative. Broadly, what types of head injuries are there? So I took this lecture from someone else's lecture, actually, and it just really summarized it well, which was primary, which is the initial impact, and then neuronal death that occurs from that, then secondary injury, and this is the salvageable stuff. So really, these are the primary injuries: impact, acceleration, deceleration. You've got focal injuries and then diffuse stuff. And most commonly we'll deal with the focal injuries, really: fractures, contusions, lacerations, and hemorrhages. But then the diffuse axonal injury, I haven't had too much to do with that, but that's just for completeness. Chetan, what do you see here?
There's a very large extradural hemorrhage on the right parietal region of this brain, causing compression with midline shift and complete obliteration of the third ventricle.
Beautiful. What do you see on the other picture to the right?
No, sorry, it's not clear, but probably I can see the same findings on the right.
Oh, as in on the there's two images, right? Like there's a one that you can see the brain, another one of the bone.
Yeah, there's no gray white differentiation on the right side.
Oh, so that's a bone window. So you.
Oh, sorry. Yeah, that's a bone window with the fracture at the adjoining side.
Yeah, exactly. Chitam, what do you see here?
Basically, there is a sulcal effacement. There is a narrowing of the ventricles with Fisher 3 findings of bleeding within the sulcal region.
Great. Grace, what do you see here?
This looks like bilateral subdural hemorrhages, and it looks more like old or subacute bleeding.
Beautiful. So yeah, the extradural was this one, and this is subarachnoid blood, and this is your subdural hematomas, and then this is just an example of a contracure injury with intraparenchymal blood there and extradural on the on that side there, and also intraparenchymal blood there. So diffuse external injury, just quickly, results in shearing forces, typically from rotational acceleration forces. It's just characterized by multiple focal lesions with a characteristic distribution, typically located at the gray-white matter junction in the corpus callosum, and in more severe cases in the brainstem. So non-contrast CT is insensitive, but MRI is a modality of choice, which is sensitive to blood and edema. So will show injury even in an entirely normal CT. And so essentially the severity is really just your loss of consciousness and how many hours or days that's occurred for. So just a concussion is less than 6 hours, and mild, moderate, severe, 6 to 24, greater than 24, and then days to weeks. And so what contributes to secondary injury? And so, when I'm looking at this, really your primary injury has already occurred. The whole point of head trauma management is to prevent secondary injury. And I think that's a really good thing to be able to state, because a lot of the things we do are literally to keep normality and perfusion to the brain to support, support the rest of the neurons not dying on you. So avoiding hypoxemia, hypotension, hypothermia, avoiding hypo or hyperglycemia and prolonged hypocarbia. And then just ensuring that your intracranial is as optimized as possible, evacuating hematomas, raised ICP management, treating edema, vasospasm, seizures as they occur. So again, really good to be able to answer that question with these categories: what contributes and how would you manage secondary injury? I'd manage my systemic factors and my intracranial things to optimize substrate delivery and demand and prevent secondary injury. So what are my management priorities? So again, pretty similar to previously, but without the rebleed type thing. I want to prevent secondary injury, but I want to maintain cerebral oxygen supply and demand. And that's how I'd summarize that. Good, so that's, that's very briefly, head trauma and just kind of just a few things to go through with some exercises. Any questions about that before we move on to C-spine clearance? 20-year-old male post-fall from ladder with a head strike. How would you clear the spine? Nice broad question here. Siak, how do you clear the spine?
Okay, so you'd clear the spine via history examination and investigative findings.
Nice.
Most prominently on the history, I'd refer to the Nexus C-spine criteria, which is 5 questions, includes midline tenderness, distracting injury, lateralizing signs. Here we go. And I think abnormal cognition, and I can't remember the last one, sorry. And then there's also a Canadian C-spine algorithm as well.
Which is more accurate?
I actually think the Canadian C-spine is more accurate, but the Nexus one is easier to remember. I think that's it, yeah.
Here's the Nexus, but you're right, Canadian C-spine is more accurate, and I'll just show you that study. So again, great that you can just recall some, I mean, again, your answer is really great because realistically, we take the whole patient into account. History, examination, investigation, always the right answer for this. And then specifically, I'd use validated rules such as Nexus or the Canadian C-spine rules. It's so funny working in a trauma center that, there's just never a time when we use this, because it's always major trauma type stuff where there's always a mechanism that needs a pan scan. So I just found that this was something that I just rarely use unless it was, some elderly patient or some patient who's had a minor fall, and then you'd use this rule. So that's the Nexus criteria. And then Canadian C-spine rule versus Nexus. Conclusions: for alert patients with trauma who are in a stable condition, the Canadian C-spine rules is superior to Nexus with respect to sensitivity and specificity for cervical spine injury, and its use would result in reduced rates of radiography. That just didn't seem to be the thing working in trauma center. Everyone got a lot of radiology. So back to the case. So you had that motorcyclist with all of these problems. You're in ED and review the updated information as per the Paramedics Act. What do you do before the patient arrives? Again, broad question requires a broad answer with hopefully categories. What do you do before the patient arrives?
Sorry, just to clarify, you've got all that information. Now you're sitting in the ED and you're waiting for this patient to come. Is that correct?
Oh, let's see. What am I trying to do with this one? Let's say this is just a new case. So this is that patient from previously.
Yep.
Motorcycle injury versus car, 80 kilometers an hour. Everything you see there, heart rate 120, blood pressure 90. Yeah.
And he's in the ED now, or is he's coming in and I've got to prepare my team?
You've got the trauma call, arrival in 10 minutes. And yeah, what do you do before the patient arrives?
Okay, so in terms of my headings for this, so I think about patient, team, equipment, medications, and then I think about my environment as well. So in terms of the patients, learning a little bit more in terms of past medical history, allergies, fasting status, whether there was any other people sort of involved in the injury, what the ambulances has done for him. And I just wanted to clarify whether he had been tubed or not. In terms of the team itself, I'd want to mobilize resources. So I want to ensure that there was the trauma team down there, including the surgeons, potentially intensive care, because the fact that he's altered GCS with a cracked helmet implies high risk of intracranial injury. You want to make sure, of course, that the ED staff and resus teams have been notified as well as the neurosurgeons in particular and theatre. I think with the equipment, if he isn't already intubated, he's a high likelihood of requiring intubation essentially and potentially transfer to the CT scanner. So as per the ANZCA professional document, you want to make preparations with regards to transport of the critically ill patient. What else? Yeah, that's probably where I'd start.
That was really great. So your framework was, just mention again, is patient, team, environment.
And then I'll probably patient, team, and environment. And then for me, sort of personal preparation. So equipment, drugs, assistance, essentially.
Yeah, great.
Sort of the things I thought about.
Everyone would have, there's some very tried and tested categorization. So this one, there's intraop, pre-op, so pre-op, intraop, post-op, which this doesn't really fit that. So you invoked kind of the anesthetic, surgical, and patient plus extra stuff. So the reason we often teach you early on anesthetic, patient, and surgical is because the place and the place and the personnel are kind of already there. So if you think about you going through all of your training as a junior, you're probably in a well-staffed hospital where you're not thinking about place and personnel, but you are thinking about anesthetic, patient, and surgical factors. Now that you're sitting this exam, your questions are going to really be very broad, and they're going to be in unique circumstances of which you are the leader running things. So I really like, so what I do is I use all those P's. Besides anesthetic, patient, surgical, you've also got place, personnel, pathology, and procedure. And if I add those P's onto anesthetic, patient, and surgical, that allows me to really hit all the high points in a very broad scenario. Just remember, there's addition to what you've already learned as anesthetic, patient, surgical, because that's very useful as a junior. Now you're putting extra stuff in. Really great answer. That's really good categories to get a broad stuff down this. Yeah. So yeah, ensure trauma call, various specialists available, check your own equipment, check that blood banks are available. I've got to update this slide since I started teaching the categorizations for this. I've noticed that the Viva's stems are so broad now, and the questions are also very, so Viva stems are very detailed. It almost takes me 2 minutes just to read them, that without really good categories, I'm definitely not going to be able to just rattle off useful information to impress the examiners. So describe your management as leader of this team. Hey, so I might ask, look, I think I've been picking on the people sitting in the exam for a while. Does anyone want to just have a go at me, just asking them what they would do?
I don't mind you asking me.
No, okay, your patient arrives now. What's your management?
So looking at the airway, so doing an assessment of GCS, and if it's less than or equal to 8, or you're unable to maintain your respiratory targets, looking at early tracheal intubation, communicating to the team how we're going to do that intubation. So thinking about the fact the patient probably has potential pre-existing hypoxia and a full stomach, just planning for an RSI, thinking about airway devices and adjuncts that we're going to use, and anesthetic agents that we're going to use, things that are going to allow us to allow control of the airway, but also thinking about increases in ICP and providing hemodynamic stability. So discussions of propofol versus ketamine, for example, muscle relaxant, so Suxin Vox. So just making sure that you're utilizing your team to get all of that equipment ready for you. And then...
And I'll actually get you, let's say you've got everything at your disposal, so you don't have to have any more discussions about it. But I want you to tackle like A, B, C with the airway breathing circulation, because the examiners will be able to then frame your answer very easily.
Okay, so shall I moving on to what my respiratory targets are going to be, or?
Yeah, go for it.
Yeah, so avoiding hypoxia, I'd want to maintain SATs of over 96, 97%. On gases, I'd want to make sure the partial pressure of oxygen is at least 11 or above. I want to maintain a partial pressure of CO2 of, well, normal, so 4.5 to 6. I wouldn't...
So let's say the patient isn't intubated and their GCS is 14.
Okay. So I would then just be looking at the blood gas and avoiding hypoxia with potential high flow oxygen or airway adjuncts in the meantime.
Okay, yep. Keep going.
Then moving on to cardiovascular, so avoiding hypotension, maintaining a MAP of over 80, replacing the intravascular volume. So just making sure that you're maintaining normovolemia. And this is a trauma patient, so there'd also be a discussion about blood. Also a discussion about vasopressors to maintain the MAP and therefore the cerebral perfusion pressure, which you want to maintain at 60 or above. Thinking about, then just moving on after ABC to just neurological things that you think about, constantly assessing the GCS, adequate sedation and analgesia, so your patient isn't agitated or stressed. And then just also looking at other things, discussion, treating seizures if the patient has seizures, and then also maintaining normothermia as well. And also looking at the blood glucose on the gas, because it's important to maintain you're aiming for blood glucose between 6 to 10 millimoles per litre. And that's it really. And also discussions with the surgeons about what their plan is for CSF drainage, post imaging, and Then,
and I've been obviously vague with the scenario. Like, there's not too much information, so you kind of have to go through step by step. So I really liked it when you went through each category, because then it again just allows the examiner to go, yep, you're targeting circulation now, you're targeting disability now. I've got a few catchphrases within each. So with airway, I look and listen. If the patient's talking to me, I believe the airway is fine, and then I'm appropriately applying maneuvers. And I like that you assessed the GCS and you're concerned about intubation. That's a good thing to talk about. The only extra thing I always do at A in a trauma patient, what do you reckon that is?
Oh, is in immobilizing the...
Yeah, exactly. C-spine immobilization. Great. And then in terms of breathing, I always say, look, listen, and feel, or get someone to do that. And then, check all my obvious stuff, which is again, respiratory rate and saturations, auscultate the lungs, check for any tracheal deviation and effort of breathing in this patient as well. Good. Let's, so there's a few catchphrases there that I always do, especially when the question is broad and vague. What is the GCS? Actually, we'll just go through this. Glasgow scale. So I think everyone knows this to death, really. Now, interesting thing in this exam, we had some past paper MCQs that always had a GCS of 12. And I remember every time I did this, I just wrote it out just to practice writing out what the GCS was. So, for this exam, I absolutely knew what the GCS was. Nowadays, I just look at a cheat sheet on the trauma chart or on my iPhone. And just remember that when I went into the exam, the multi-choice question was there, but they changed one line, like one word, from a positive to a negative or something like that. And the GCS was actually 11. And it was so strange to me, thinking, I'm so used to putting 12. Am I thinking the wrong thing? But it definitely wasn't. I'd done the GCS so often, I knew my GCS, and they just changed one line. So just be really careful on the MCQs because they will change things. So yeah, this is essentially a GCS. We don't need to go through it because everyone really does know this. If I was ever to talk about this in the setting of, say, the trauma, I wouldn't say GCS. I would just go AVPU, alert, and then responding to voice, pain, and unresponsive. You just want to bypass any conversations about regurgitating a GCS in this exam, I'd say. Indications for intubation. Hey, so again, this is a really great exercise for going broad in this exam. What are the indications for intubations? Take a minute and write those indications down.
So broken down as logistic and clinical issues as indications. In terms of logistic, if at all the patient needs further investigations and is not cooperative, so that would be a factor. In terms of clinical, I'll start off with airway, breathing, circulation, disability approach. In terms of the airway, if the patient doesn't have a patent airway or if there's signs of airway obstruction or threatened airway, so that would be an indication. In terms of breathing, if the patient is hypoxic, hypercarbic, so that would be an indication with low SATs and other chest findings like pulmonary contusion, flail chest, or a massive hemopneumothorax. In terms of circulation, if there's hemodynamic instability characterized by major blood loss with severe hypotension, that would be an indication. And in terms of disability, again, if the patient has got loss of consciousness or neurological issue, low GCS, or any intracranial issues, so that would be an indication too.
Yeah, good. So again, I actually really like your categorization. Because, essentially what I've gone through is what you've said. I've got my airway, breathing, circulation reasons, and then I've got logistical reason, enable CT scanning, stabilization for transfer. Yeah, excellent. So yeah, specifically respiratory arrest, poor oxygenation, ventilation, which you mentioned, GCS less than 8, bleeding into the mouth, so anything where I might have potential problems managing the airway later, seizures, and that's good. How would you program the ventilator? Yeah, so I mean, I put this when I felt like there was a bit of contention about what you should really do, but I feel like it's just not that contentious anymore. I'd always go for high oxygen levels initially and then titrate down to SATs greater than 97. Just very normal, AME and a normal end-tidal CO2, or rather PA CO2 of 35. I'll probably change that. And no PEEP unless there's an issue with oxygenation. I really don't want to increase my ICP. Okay, so let's say circulation, large biopsy axis, arterial lying, aiming at CPP of 70, assessing the source of bleeding, expected blood loss. So assuming the patient has free fluid in the abdomen and looks like a class 3 hemorrhage, they also have GCS of 8 and likely head injury. What BP would you aim at? Chetan, what do you reckon?
So this is a patient with TBI and also abdominal hemorrhage, is that right?
Yeah, that's right.
Yeah. So I would, so basically there's conflicting priorities here because I would want to maintain a MAP of 80 in someone with traumatic brain injury, but given the fact that this patient has got a class 3 American College of Society hemorrhage, which means that he's lost 1.5 to 2 liters of blood. So I would aim at a lower MAP than 80 to facilitate surgery, abdominal surgery. So my MAP would be 65 to 70.
Actually, so what do you mean? So what is this I feel like you're right about mentioning there's conflicting priorities, but I want you to specify them again. What are your conflicting priorities with blood pressure here?
My conflicting in traumatic brain injury, I would like to maintain a MAP of 80 to maintain a cerebral perfusion pressure. And but in this case, since this patient has got an intra-abdominal bleed, which is massive, I would lax my my blood pressure range down to 65 to 70 of MAP.
Yeah, right. And why is that? What is the, say you've got a free fluid ruptured vessel in the abdomen trauma, what's that called that you're trying to aim at with a low blood pressure?
It's called permissive hypotension as part of
permissive hypotension. Yeah, okay. I haven't had permissive hypertension, but hypotensive resuscitation, absolutely. Yeah, so good, yeah. And what's the aim of that? Why do we
basically it's a damage control resuscitation, which again aims for a lower blood pressure so that there's further less bleeding.
Yeah, good. Yeah. If I use hypotensive resuscitation, I get less blood loss, and there's more likelihood of formation of a clot that doesn't get blown off. And it really is to try and maintain just the lowest blood pressure that still perfuses the brain. You've got a real problem here. So I think if you ask many different anesthetists what they would do, there's kind of an evidence-free zone. If you've got a serious problem there, they're going to die. If you've got a serious problem there, lowering the CPP is going to be a problem. So I would just choose somewhere that's reasonable in between, and just outline the fact that you really can't have, you really can't solve this problem easily, and it's a rock and a hard place. Yeah, any questions about that? Yeah, so disability, how do you assess severity? Really, GCS is probably the easiest way to do that. What are the signs of imminent coning? Yeah, so unconscious hypertension, bradycardia, and dilated pupils. And the immediate management. So this is pretty similar to the last time, where you have, again, a head trauma patient, suddenly the ICP increases, you've got imminent coning, and all signs point to a really raised ICP. Positioning, pharmacological, physiological, and then surgical evacuation is what I revert to immediately. Mannitol. So, I mean, again, sometimes there's just that detail that you get in this exam. What percentage is mannitol? What does that come in? Luke?
Mannitol is 20%.
Great, what volume?
And I give 0.5 grams per kilo, which is 2.5 mils per kilo as a bolus.
Yeah, fantastic. So it's really good to just know this. So I mean, there's 100 grams in the bag, and so when the surgeon asks you to give a dose, it's great that you most times you get asked for 0.5 grams per kilogram, and you know what to do with that. And so it's grams times 5. So 0.5 times 5 is 2.5, and that's mils. And so that formula works for that. Good. Okay, 25-year-old man, history of blunt trauma to the right side of his head, has a fixed and dilated right pupil. He has been intubated and ventilated in the emergency department after an initial GCS of 15 on admission, which has now fallen to 3. Evaluate the pharmacological and non-pharm methods to manipulate this patient's intracranial pressure. I think we've kind of gone through this already. So again, yeah, for this particular, I think what I used to do when we had a bit more time for these sessions was to get you to write a short answer question, summary statement, definition, ICP, Monroe-Kelly doctrine, and then graph of volume versus ICP. And then the factors essentially blood, CSF, brain, interstitial fluid, and bone factors, and then just try to give as much detail about each of those. I think let's move on. So yeah, prognosis was often age in high-income countries or GCS in low-income countries. And the prognostic factors, GCS, pupillary reaction, major extracranial injury, and then CT, petechial hemorrhage, loss of third ventricle, subarach bleed, midline shift, and unevacuated hematoma. I think probably just useful to have a few of these to know if your situation is going to be bad as the patient presents to the ED or to theatre. And a lot of these things really are kind of obvious. If the patient's unconscious with no pupillary reaction and lots of other major injuries, that's kind of obvious that your prognosis is going to be bad. So I don't think this is something you definitely need to memorize because a lot of it's just obvious. Can anyone tell me about the DECRA trial? That's pretty fair if you can't. This was going along as I was in my training at the Alfred. Multi-center RCT comparing deep compressive craniectomy to best medical management. And so you had improved ICP, but poorer long-term outcomes, and no difference in death between the groups. But again, there's a lot of criticism. So the threshold for defining increased ICP and the time allowed before declaring ICP medically refractory are not what many practicing physicians would consider. And out of 3,500 eligible patients, only 155 were enrolled. So really doesn't seem to be necessarily generalizable. And then despite being randomized, more patients in the craniectomy arm had unreactive pupils after randomization, but before surgery than patients in the medical therapy arm. It just makes it really unsatisfying that that this trial didn't have better randomization. Hey, so I mean, again, let's move on just to get to the more of the interesting stuff in regards to this exam. Let's go, Ash. When would you use Tiva propofol versus volatile for neuroanesthesia?
Tiva would give you more of a smoother emergence. You can control it a bit better in terms of like coughing.
Anything else?
And yeah, with blood pressure as well.
Yeah, so for me, similar hemodynamic stability, but propofol decreases ICP better than CPP and has better CPP in elective craniotomy. So yeah, that's kind of where the evidence is ICP rather than a lot of the other stuff. John, when would you use remifentanil? What are the benefits?
I'd use remifentanil if I was going to go for surgery and I wanted to control, well, initially to have a nice smooth intubation. So it's a very strong, potent opioid, so I could intubate the patient safely without hemodynamic changes. Also the bits during the surgery where there is going to be increased pain, so pinning and plating and opening the dura. Essentially, I find it a lot smoother. And again, when patients waking up, they can wake up with less bucking and coughing, which is going to cause raised intercranial pressure again. So I use it for that as well.
The evidence is quicker eye opening, very titratable, like you mentioned, and it can also provide that muscle relaxation, but may have a higher opioid requirement post-op. But often, Remy, because let's face it, like often the surgeons want urgent neuro assessment post-operatively. So whenever I need urgent neuro assessment, I really want to have a short-acting opioid on board. Sorry, John, what were you going to say?
I was just going to ask, with regards to Tiva propofol rather than volatile, is there a role for its antiemetic function compared to volatile? Because neurosurgery is known to be highly emetogenic. Has that been proven to be a case, another reason for using propofol or not?
The recent SAMBA guidelines don't say that neurosurgery is high emetogenic. Look, I could be wrong about that. Maybe I'm missing something there, but I'm so certain that it isn't one of them. So yeah, I'd say not for antiemesis. No, that said, if they've got PONV, that's just another reason, or high risk of PONV. That's just another reason for it. Yeah.
Can I ask Lahiru? I always say quicker eye opening, early accessibility or whatever. And then you get asked about, what you're doing for analgesia, and you say, I give 5 of morphine as they're closing the scalp. Like it sort of seems to be like, you're using remifentanil for early accessibility and using a long-acting opioid right at the end, right when you want to assess them. Like I find
I think to me, it's not too much of a problem. First of all, I'd probably use fentanyl over morphine, but again, I don't care if people use morphine. But the fact is, it's often a very long operation, and the fact that it's just 5 of morphine at the end, then you can account for that. Whereas if you've given morphine regularly and then you're at the end of the surgery and you're not really sure where you are, I think that is. But you could get let's say for the exam, what are you going to say? I'll just say 50 of fentanyl, plus you've got local blocks all around the head. That usually sorts that problem out, I think.
Yeah, okay, thanks.
Friend says, no clinical benefit adding paracoxib to the mixture that you already have for these cases. Nitrous versus air. Does anyone use nitrous for their neuroanesthesia? No, okay. The evidence shows that at best, there's no harm or neuroprotection, but there's no convincing studies, but theoretically at worst, you could be neurotoxic. It might increase ICP and give a poor surgical field. Volatiles greater than 1 hour is a risk factor for PONV, and you want to avoid steroids and head injuries. So propofol Tiva has some extra benefits for PONV there. Yeah, absolutely. I absolutely take that. Subarachnoid hemorrhage, target euvolemia, harm with aggressive fluid resus, as someone already mentioned. Routine phenytoin is not recommended. Modest BP elevations less than 160 don't need treatment. Routine pulmonary artery catheter is not recommended. And then, CVC solely for central venous pressure and fluid management is not recommended, and also keeping your BSLs less than 11. Just reasonably controlled BSLs. So that's the kind of the trauma stuff. So in summary, we went through trauma and head injury, primary then secondary survey, and the whole point of our anesthetic is to prevent that secondary injury. Sorry, secondary survey, primary injuries, and then secondary injuries being the preventable things we need to sort out systemic point of view and intracranial point of view. We talk about C-spine briefly and being able to invoke an assessment of that using one of the 2 rules, and then trauma management sequence. And then there's always conflicting priorities that you need to be able to talk around. And then ICP management, which is very similar to the framework of ICP management that we already went through. Positional issues. You'll often get a question about what are the hazards of X position for patients under general anesthesia and how they can be minimized. And I just want to show you my structure. So my first opening stem with these short answer questions is to say the hazards relate to the position itself, also the patient comorbidities and the type of surgery in relation to that position. So that's kind of my complete answer summary statement that I write in any SAQ. I'm pretty sure I got that out of a final exam, examiner's report in one of their past papers. Now talk about all the physiological stuff. So the stuff that we care about, there's always respiratory effects of having an odd position. There's always cardiovascular effects, especially venous air embolism. Then there's CNS effects. Then nerve damage, because it's an odd position, like say you're prone or you're sitting up. You really need to make sure that all the positions are neutral. With prone, there's ophthalmic visual disturbance problems. And then posterior fossa has a whole bunch of other things, which is laryngeal edema, pneumocephalus, and also quadriplegia is a risk. So I just wanted to be able to talk about, with a framework, any positional issues as best as I could. Oh yeah, that's right. And pressure injuries, and then accessibility to stuff, whether it's the airway or being able to manage a problem like chest compressions in a prone patient or a sitting patient. And then the next part of it, once I've outlined my problems, physiological pressure, accessibility, and crises, then risk minimization. So pre-op assessment to assess for any of these problems previously, any nerve issues, etc. Limitations because maybe they've got some kind of disorder where they have flexion deformities, and then careful positioning, staff, pressure care and padding, anesthesis for the airway, the C-spine and the head, avoiding disconnections of all your monitors and your lines. Then monitoring access to art line, often 2 drips, extension tubing may be required, securing it very carefully. And then if it's posterior fossa surgery, you might want any of these monitoring things like EMG or SSEP, somatosensory evoked potential. I've never actually used those for posterior fossa surgery. Just to go through ICP monitors. So some of the questions that there were in the past, list the methods of assessing intracranial pressure, and then evaluate the role of ICP monitoring in the setting of traumatic brain injury. And in this, sorry. So assessment method, non-invasive clinical CT signs, invasive intraventricular catheter, EVD or Codmans. And the benefits, the strong correlation between ICP and traumatic brain injury. It's well established and recommended in traumatic brain injury, and allows the measurement then therefore of CPP, because you need to have a blood pressure measurement plus your intracranial pressure measurement. And then the diagnostic and therapeutic roles for these like EVDs, you can actually take out some CSF if the ICP increases. Yeah, Codmans is an intraparenchymal, absolutely. Sorry, I've written that incorrectly there. It may be the first indicator of worsening status, allows detection of impaired airway regulation. ICP waveform indicates brain compliance as well. It's pretty cheap, and treatment of ICP without monitoring may have risk. But the risks are, so the Cochrane review, so there's no RCT at this time supporting ICP monitoring in TBI. There's also an infection risk after about 5 days, hemorrhage on insertion. And when you see them inserting these, it really is just a landmark blind approach. So anyway, it's definitely not without risk. Difficult insertion with brain swelling, and ICP may not be uniform. So even if you're measuring it in one part of the brain, there's nothing to say that there's not a high ICP pressure or tension in another side of the brain. Okay. Awake craniotomy. Now, I always feel a bit silly talking about this because I've never done an anesthetic for an awake craniotomy. Has anyone done an anesthetic for an awake cranie? Emily, what's your method? Take us through. And someone's just said that looks like you, Chitan. Hey, Chitan, that's not you, is it?
Sorry, my headphone microphone's not working. So I've seen only 2, so it's a pretty small sample size, both done at the Austin and both done with the same team, so it may not be that representative. Both were done with scalp blocks, which were facilitated by a dexmedetomidine infusion. The patient was awake initially, and then after the eloquent area had been assessed intraoperatively, we then induced and tubed.
Say it again, sorry, and then you do the scalp block?
Yep, so scalp block with a dexmedetomidine infusion, sedation for the first part of the case, dexmedetomidine sedation. Once the surgical target area had been...
So they're just sedated with dexmedetomidine, even, and a scalp block, even as they're getting down into the dura and opening the dura?
Yep.
Good, they do the resection, patient's awake, talk.
Yeah, so when the neurosurgeons got to the eloquent area that they were dissecting near, there was a neurologist in theatre who assessed the patient, and when everybody was happy, we just induced for general anaesthesia.
Fantastic. Okay, good. And so that's definitely just sounds like an awake asleep approach. While you're there, what is we'll get to that. No, that's great. So indication, as you mentioned, so to talk about space-occupying lesions adjacent to eloquent areas of the cortex, and really allows resection of tumors in sensory, motor, speech areas of the dominant hemisphere that would otherwise be unresectable. So stimulation or lesion generation of deep brain nuclei for Parkinson's as well, and then epilepsy. So these are the indications. And yeah, the problems are, confusion, communication, anxiety, inability to lie still. Significant dural involvement means they'll have more pain, and obviously any experienced members of the team as well. And then there's always the complications. There's so many things that can go wrong if things, having an awake patient having this reasonably major operations, obviously fraught with problems, including airway obstruction, aspiration, GA conversion, seizures, nausea, vomiting, dysphoria, air embolism as well. So preparation. You know, obviously a whole bunch of things. And so again, you know, it would be good, Emily, like that method that you've seen, that's just such a simple method that it's almost worthwhile just having your method there. Like if anyone has to talk about awake cranies, either you've seen one and you can talk about it with knowledge and experience, or you try to adopt someone's method. And I think that's the briefest method I've seen, because usually you have this kind of awake, asleep, and then awake again, and then asleep again kind of method, especially like while they're doing the pins. You know, so the simpler these techniques are, especially when you haven't done them, the easier it is to just describe, and you know it's been done, so therefore it's completely appropriate. That's a thing. So yeah, preparation, you do the positioning. So Emily, tell me about your scalp block. How do you do that?
With difficulty. So the basic sort of premise is you've got a series of nerves that you're needing to block over the face, which are basically like trigeminal derivatives, and then around sort of the back of the head, they're sort of off the cervical plexus. So look, I'm definitely not an expert here, having done it a grand total of 0 times, but in theory, your nerves on the face, let me see if I can remember any of them. Yeah. So you've got a supraorbital point, which is just above the eyebrow. You're putting in about 1 mil of your local anaesthetic, and then you direct more medially to go for the
supratrochlear.
Yeah, great. And they're both, I think, V1 distribution organs. Then you've got a, oh gosh, temporozygomatic, I think.
Zygomatico-temporal, yeah.
There we go, something like that, which is slightly lateral to sort of the distal eyebrow, where you can sort of feel the junction of the bones. Mm-hmm. Then you come down to the auricular, and that's a V2 distribution. Then you come down to the auricular temporal, which is just in front of the tragus, which is, I think, V3 distribution. They're sort of your 4 points that will cover the face itself. And then moving behind the ear, you have the greater auricular, I think, which is of the cervical plexus. And then you need to get your lesser occipital and
good. Look, that's really good.
Which is sort of around to the occiput, but you just get the surgeons to sort of top up any deficiency.
Yeah. And I remember learning this and then actually going to do one, and literally I just put local around the head and you know, drop my mic at that stage. So yeah, I mean, dexmedetomidine is great. Some people run REMI, some really low dose propofol TCI, and do those blocks. And then once so you say you've got all of this running, you've got the blocks in. Often you might insert the head pins with an LMA or with sedation, and then awaken them once that's all sorted. Then you access the cortex of sleep, so you might get them, you know, you might do the incisions and get down to the area while they're asleep, and then awaken them at that point. Increase propofol, insert Remington, insert the LMA, drape isolate axis, prevent claustrophobia, tape eyes, all of those things are relevant, and then awaken them for the resection. So when dura open, decrease the propofol and Remi to remove the LMA. Questions regarding motor, proprioception, and speech. So this is an article that I sent everyone in the email trail. So someone's just kind of given a document about how they do it. Again, I feel so odd talking about this because I just haven't done it. But that's, you know, once they've done the resection and they've done everything they need, then you're happy with it. You can you can get the patient off to sleep, to close, deepen anesthetic, reinstitute the LMA. When I think of the real points of this, you know, it's not necessarily the whole process in too much specifics, but it's knowing that all I need to do is to get the patient comfortable with these blocks. So patient preparation, beforehand, making sure that, you know, that things are going to go as well as possible. Patient selection counseling is really important. And then doing my sedation technique, doing my local anesthetic technique, and getting the patient comfortable, making sure that they're all good, and then asleep for access to the dura and then awaken until, and then you do the resection awake because all the fast acting, short acting stuff is gone. And then once the surgeons are happy, getting them off to sleep. So the difference with Emily's technique was with such a good anesthetic technique and dexmedetomidine and whatever else, you can do the whole thing, getting down to the eloquent areas or the tumor resection completely awake or just minimally sedated. So either way makes a lot of sense, but just have a way you can talk about easily.
Leo, can I ask a question?
Of course.
So with this this block to the nerves, these are nerves that supply skin. Do they actually supply the skull itself, or is that the role of the REMI?
No, they supply the dura as well. Look,
okay.
It's been a while since I did this, but I'm so certain that it supplies every part of that.
Okay.
Yeah. So if you get good scalp blocks, you just don't. If they work effectively, you don't need any more analgesia for the time that the local anesthetic's working.
Okay, cool, thanks.
Good. Hey, so the next thing is craniotomy. We've got about 15 minutes left, so I'll just try to kind of go through and stop at the most important points. Metastatic tumor in the brain, previous breast cancer, what do you want to know on preoperative assessment? So I might just ask, Siak, what's your structure without going into detail? Pre-op assessment of this. Michael?
Oh, sorry. I'm just previous breast cancer resected. What do you want to know pre-op assessment? Okay. All right. So overall, so I want to know about the tumor itself, and there I have sort of 5 M's. So mass effect, metastases, like other metastases besides the brain, essentially, because you're thinking the breast was the primary. Medications. Metastases, medications, mets, metabolic effects, and the mental effect that it has on patients because they're often pretty distraught. Into other things that I want to know. So I divide my pre-op assessment into qualify, quantify, and then try to optimize the risks beforehand, essentially. And so I'll split it into those. That's my overall structure.
Yeah, that's really good. So in addition to my usual assessment, because everyone knows I do an anesthetic assessment, I'm going to quickly target mass, mets, metabolic, mental state. And I also, because I'm using my SSCCT framework, I'm also thinking what was the cause of this. So breast cancer caused by whatever BRCA gene or whatever else. And then, chemo and radio is such massive consequence of anesthesia that I might be considering that as well. And then examination ICP. So yeah, my kind of EMS framework is great for the tumor and a few other things, but I definitely think about the treatment as well. It's examination, ICP, neuroexam, and investigations, a whole bunch of stuff because it's a tumor in the head. So that again, that was brief because I feel like the biggest takeaway point of the craniotomy assessment is being able to do a quick, thorough assessment, write it down, verbalize it, and sound sharp. Transsphenoidal surgery. What are we often resecting with this approach? So yeah, often it's pituitary surgery. And then again, there's a whole bunch of stuff with mass effect for this, but it's very specific to that area. Not only of headache, seizures, ICP issues, focal neuro, but cranial nerves and visual fields and coordination can also be affected. So now the mass effect of transsphenoidal problems becomes a whole thing. But also metabolic is a massive thing with pituitary things because all of your hormones, especially growth hormone, can be a massive issue, or adrenocortical hormones can be stimulated by it as well. So Cushing's, obesity, diabetes, hypertension, potassium problems. So again, I just want to really emphasize the fact that I always want to have my frameworks really, really rigorous here because then I can just keep adding things to the framework and it helps me to memorize things in a really coordinated fashion. So intraoperatively, look, the way I think of it, it's a long glorified fest, plus craniotomy, plus VAE, long surgery, which is pressure, handover, warmers, fatigue of staff, access problems, throat packs, major hemorrhage can occur. So there's a lot of little issues, but again, each one of these issues I know as a bundle of knowledge. Postoperatively, diabetes, pituitary hypofunction, and CSF rhinorrhea. Okay, so just to give someone this situation, I might just get a volunteer. So 50-year-old prolactinoma, type 2 diabetic on insulin, ex-smoker, asthma control with serotype Ventolin occasionally, nil cardiovascular problems, no allergies, nil issues from prolactin secretion with medical management. And in PACU, this post-transfemoral hypophosphatemia is 14 hours. So they're now in PACU, having difficulty breathing. Patient seems to be struggling with small tidal volumes and noisy breathing. Sats are decreasing to say 90% as you called in, not fully conscious after extubation. They're kind of sedated, they're alert to a bit of voice and pain. You're the only doctor nearby, as the anaesthetist is an ED with a failed airway, so they're busy. You need to manage the situation. Yeah, who hasn't had a go about, I guess, Vivet stuff? Who wants to have a go?
I'll have a go.
Go, Amy.
Firstly, I would take an ABCD approach after checking there are no dangers in the area. So assessing the patient's airway, it describes that she's got, is it a she? Yeah, maybe. It describes that she's got noisy breathing. So it may be that her airway is not patent. So I'd try some airway maneuvers and apply oxygen and see if maybe a jaw thrust or a head tilt helped.
You do those, it doesn't really help too much. You put oxygen on, and oxygen is already on, and it's on 15 liters, and the sats are about 88% as you're doing that.
Okay, so I've not adequately dealt with the airway, and the sats are falling. The patient's fully conscious, so there's no airway adjuncts I can try to help.
They're not fully conscious. I'd say they're alert to voice and then pain sometimes.
Okay, so the possibilities as to why the patient has got poor airway, especially after not being fully conscious. Oh, sorry, not fully. I read it as fully conscious. Not being fully conscious after extubation, or they could have. It could be an anaesthetic cause or a surgical cause. So anaesthetic causes may be that they're inadequately reversed. So I could try, depending what they've already had, and maybe if they've had neuromuscular monitoring, I can look at that and try perhaps Anaesthetics to see if that would help.
You note that the trainer 4 was greater than 90%, and the patient was given standard reversal after, they didn't have too much extra dose of muscle relaxant, so they adequately reversed.
Okay, and other anaesthetic causes for this could be that they they've got opiate toxicity. So I could check their pupils and see if there's a role for giving some naloxone to see if that would help.
You give some naloxone then there's no improvement.
Okay, and finally, it could be that they've got they're still got a lot of propofol on board, but there isn't a huge amount I can do about that other than supportive.
The TCI pump was down to 0, so completely no propofol left.
Okay, so I feel that we can exclude anaesthetic factors. Surgical factors.
As you were doing this, the sats are now 60% as you're ruling out factors.
Okay, so I'm going to have to intubate this patient, and I would call for extra help if available. I would like my anaesthetic nurse to be with me, preferably if there is someone senior about, I would have them join too. But even if they aren't, even if they're not, this is an airway emergency, so I'm going to have to intubate this patient. So I would have my anaesthetic machine handy and draw up medication for. I would draw up propofol.
In recovery. Do you want to go to theatre or stay in recovery?
It depends how far the theatre, assuming it's right next to theatre, I would rather be in theatre because I've got everything that I need available. But if not, I'll just get the emergency airway trolley and intubate in theatre.
Sounds good.
I would quickly prepare equipment and drugs. I would want propofol, a muscle relaxant. I think I would use succinylcholine because they've just been reversed. I just think it might be better to use Sux now, and it would give me rapid control of the airway. And I would also still want to,
Is there a problem with giving other muscle relaxants after giving neostigmine?
they may be less effective.
Really?
I don't know.
No, that's right. If you, this is very common in the exam. You say something that's a little bit not, they'll come at you with something like, oh, why would you do that? Like they'll constantly be interrupting you in the exam. Yeah, I'd say that it's not, I mean, if you gave sugammadex and then gave rocuronium, absolutely. I'd be like, yeah, well, that's not going to work in the same way. But neostigmine, and then you give any other relaxant is completely fine. I haven't heard anything about that.
Okay.
Please correct me if I'm wrong. But yeah, see, Sux is complete. If you just said I'd give Sux, I would never even ask you a question. So that's
okay.
Keep going.
And they've just come out of surgery, so they don't need a rapid sequence induction in terms of prevention of regurgitation. I would also want to prevent they've just had neurosurgery, so I want to prevent any spikes in blood pressure. So I'd also have some alfentanil ready. Yep. I would have a video laryngoscope just in case there's any airway edema. It just gives me a slightly better view.
Let's we're going to pause there because you're managing this well. You've gone to a familiar environment. You're progressing down the right way. You've got all the equipment, and you're about to go in with year 2. What are your surgical differentials that you're about to mention before we started going down this path?
Depending on their positioning, they might have some laryngeal edema, which could be causing airway obstruction.
Yeah.
And it could be that it could just be that they've got cerebral edema that is causing a reduced GCS and therefore lack of airway tone, loss of airway tone.
Good. And as you go in, you see a throat pack, you remove it, and everything resolves. This was
I was going to ask whether you have nasal packs in the nose as well.
Yeah. And it's one of those funny things where it used to happen, like, say, once a year, you'd have an M&M with a throat pack issue because they didn't have the stickers. And they had multiple teams working and handovers. And it just used to be one of those things until this, and that's right. Also the throat pack after redraping would often be removed. So until the throat pack became part of the surgical count, it's far rarer now to have a throat pack left in, but it used to be, just happen every couple of years or so. Yeah, very good. In terms of how you handle that, yeah, like either way, you had to manage it the way you're going to manage it. Like this was an airway breathing problem, and you're going to get to the solution eventually. In real life, it's so much more hazardous because it's a redo airway, so there's just more stuff around. But yeah, no, you managed that really well. Good. And when I think of the causes, like this is kind of a decreased conscious state type thing plus failure to breathe type thing. So I'm targeting both of these and trying to think of all my differentials and rule out things as I go. Hey, so we've just gone through positional issues, ICP monitors, awake crani, transphenoidal surgery pack. Again, I'm really just targeting what I think is the most important high yield stuff in each of these, so we don't kind of bore you to death and go on for 6 hours with neuroanesthesia. That I don't think is the right evaluation form. Hey guys, that's the end of our talk. I'm pretty sure Alice or Maddie would have sent you a feedback link. Is that right? Yeah, if you're able to fill that out straight away, just so that, just so that if I don't fill it out straight away, I just never end up filling it out. So please fill it out right now if you can. And I'll stick around for another few minutes. If anyone has any questions, thanks so much for participating and letting me put you on the spot. I know that's always a bit intimidating and scary. And yeah, please tell me like straight away if you want me to edit you out of the video edit that I'll chuck up on YouTube. And I'll send a link for that hopefully in the next week.
Thanks, Lahiri. That was awesome.
Thank you. That was great.
Yeah, that was great, Lahiri. Thanks, mate.
Thank you.
Thank you.
Thank you.
Okay, team. See you soon.
Thank you very much.
Thanks, Lero. Cheers.
Thank you.
Thanks, Ladle.